How are you guys doing? How are things? Some of you might have had the prelims started, some of you must have the prelims completed. And this series of FARRE for pathology, pharmacology, and microbiology, we're starting in the second year FARRE. So I'll be having two sessions of hematology, like I guess told you in the WhatsApp group. And we'll be having more of micropharma sessions in between. Then we'll come to systemic pathology. The last will go to general pathology. That's how I organize the FARRE of pathology for now. And I'm sure Star sir and Anashama will take care of their respective subjects. Good evening, everyone. Good evening, good evening, good evening, all. So this time FARRE, I've made it a little bit different. So I want to revise almost everything which is there in the exam, with respect to exam, not just the important topics. So what I'll be doing with every FARRE is, initially you will have a sheet like this. So this is going to be the cheat code for you. What it will have is the final moment when you go before the exam, don't know what to do with RBC disorders, just watch this sheet. Just go through the sheet, right? So it will have the important keywords, how to come to a diagnosis. The goal here is to make sure you don't make a mistake in long answer questions. If the diagnosis is sorted, I'm 100% sure you will be able to write a little bit about that in the pathogenesis, right? Definitely, fine. Yes, definitely, Tejas. Like I said, I'll be covering almost every topic which is important from a university point of view, not just for your simple overview of it, right? Okay. So what we'll be dealing today is we'll be dealing about all these 17 diseases today. So everything important from an exam point of view, wherever required, we'll put more emphasis to learn the conceptual understanding as well. Though we know it already, we'll just re-revise them. That's all right. So all these lectures are based on the notes of Nishchay batch, whatever you've already read. So it's definitely going to be much more useful for you, right? Yes, this for university exams, going to be primarily based for university exam, right? So like this, you'll have one sheet for every FARRE what I'm going to take. Obviously, for general pathology, I may not have diseases. We'll have different conceptual understanding for general pathology as a single sheet, right? This will be the starting point, and what we'll be ending with the FARRE is with classical clinical scenarios like this, right? So if it comes in a long answer question, what will be the diagnosis, right? So we'll start with a keyword, a quick wrap up of everything, all the diseases, what is there in the first sheet we'll be covering, and we'll have a final endpoint where we'll have a clinical scenario. I'll give you highlight the important key points, and you're going to tell me the diagnosis, right? So if it's ready, let's start the game as usual with a smile. This time pathology is not going to be difficult for you. Trust me, we'll make sure that you read the FARRE before the exam and make sure all the required answers come from the exam FARRE itself, right? I'll share the PDF with you, but still I would suggest you to more than writing the copy in the hard copy. If you have your already written notes, mark the important points, keywords, and please, 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 let's have a live interaction, because this is a revision for you. Whatever you know, answer whenever I ask you, because answering here is nothing but a revision for you, right? Okay, great. Parvin, I will share the link later on. Fine. Okay. So let's start with, first we'll go quickly and read through all the things, the keywords. Then we'll go to individual diseases, right? So if you have a patient with hereditary spherocytosis, first of all, it's an autosomal dominant disorder. So it will have definitely presenting during later adult, but there may be recurrent episodes from childhood, right? Not severe enough. Splenomegaly, spherocytes, and they should be Coombs negative. This is a very, very important finding here. Presenting during adults, recurrent episodes of icterus, and having splenomegaly in adult and gallstones, gallbladder calculi is a very, very classical feature for hereditary spherocytosis, right? Next, G6PD deficiency, right? I'm going to ask you questions. In between, I'll definitely ask you questions. I want you guys to answer. Only left side is hearing. Is that an issue for others as well? Are you hearing only one side? Do let me know. Okay, perfect. G6PD deficiency. The most important thing in G6PD deficiency is a trigger-based hemolysis, right? Never ever forget it. It's a trigger-based hemolysis. The trigger could be any fever. Even a viral fever can be a trigger. Like that drugs, primaquine can be a trigger. It's a very, very important drug which you have to remember, right? Bite cells on peripheral smear and Heinz bodies. Can anyone answer me which stain you will see Heinz bodies? All these are classical clues for G6PD deficiency, and it's an X-linked recessive disorder, right? Perfect, right? So you will see them in new methylene blue stain. You won't see them in Leishman stain. You will be seeing them in a new methylene blue stain. Do remember that, right? The third disease, this is a very classical disease. It can come in an MCQ also. Very unlikely to come in a long answer question, at least for an undergraduate purpose. Maybe when you go to medicine, might be important. Early morning, first urine alone hematuria. There's no other differential diagnosis for that. The answer has to be a paroxysmal nocturnal hemoglobinuria, right? Dark urine in the morning. Very, very, very important. And the next two are even more important when you come to neat PG9ACT. You have a pancytopenia in the peripheral smear, but the bone marrow is cellular. Hypercellular or normocellular doesn't matter. Pancytopenia generally will have hypocellular because of aplastic anemia. Cellularity increase in the bone marrow plus your pancytopenia is diagnostic of paroxysmal nocturnal hemoglobinuria. But I would always insist on being very strong in the history. Early morning, first during hematuric, next during normal is your PNH, right? Next, sickle cell anemia. Sickle cell anemia does not present with anemia. Please do remember that. Thalassemia will present with anemia, fatigue, and everything. Sickle cell anemia presents with, by default, painful crisis. They don't present with anemia, they present with painful crisis only. Remember them, right? Can anyone give me one example of the sickle cell anemia vaso-occlusive crisis? Any one thing? There is one more information given there. I don't want you to tell that. Something other than dactylitis. Anything other than dactylitis. Good evening, Blessing. Anything other than dactylitis. Dactylitis is definitely an important thing. Apart from that, anything else? It could be non-healing ulcer in the legs. It could be unexplained abdomen pain leading to autosplenectomy, right? It could be pain in any of the tiny vessels which will block by reversible sickle RBC, which causes vaso-occlusive crisis. Priapism could also be an example of vaso-occlusive crisis. Very, one of the worst crises is your acute chest syndrome, mimicking MI. All of them can be perfect. All of them can be examples of vaso-occlusive crisis, right? Great. Okay. Beta-thal major. The clue is here. Infant. And one more important information for beta-thal major. If you see any question calling this transfusion dependency, there's no anemia for an undergraduate. It is transfusion dependent apart from beta-thal major. Without transfusion, the kid will not be able to survive. Presenting early in life, 6 months or age, is thalassemia major, right? Thal minor, mild. Its thalassemia minor is like iron deficiency anemia, but we always emphasize on thalassemia, right? Because your Mensters index is less than 13 and your RDW is going to be narrow or normal, right? So narrow RDW, again lesser RDW, and Mensters index less than 13 is diagnostic of thalassemia minor. Do remember them, right? Perfect. Okay. So these are just keywords. I'll obviously go into the diseases very soon. Fine. Next comes to autoimmune hemolytic anemia. We have two different types of autoimmune hemolytic anemia. One is a regular autoimmune hemolytic anemia. They don't have any keyword. You have spherocytosis in the microscopy and Coombs is positive. My diagnosis, warm autoantibody and autoimmune hemolytic anemia. Warm is the most common subtype and warm will always have IgM, right? There is a mnemonic which I must have told you. Warm is garam, right? So G for G, so it helps you to remember IgG is the most common antibody, not IgM, IgG, fine. Cold has a very classical finding. Can anyone tell me the name for this phenomenon? Acrocyanosis in the cold. Acro is the periphery, right? Okay. Definitely, Tejas. It's just an overview of what I am going to talk here. Definitely, we'll go to individual diseases and explain in detail. Don't worry about it, fine? Acrocyanosis in the cold. Acro is your periphery, right? Periphery will become bluish in color on exposure to cold because these agglutinated cells will go and block them. We call them a Raynaud's phenomenon, right? Raynaud's phenomenon because of RBC agglutination, that's classical. And this is IgM, pentameric, that's why we have the agglutination. And you have, this is the most important key factor, RBC agglutination in the peripheral smear is diagnostic of your cold autoimmune hemolytic anemia, right? This is very rare. I am putting an into mark because you might not get them in the real life. Very unlikely to get them in an exam as well. If you have an autoimmune hemolytic anemia with predominantly intravascular hemolysis, okay? Intravascular hemolysis, the only autoimmune hemolytic anemia which presents intravascular hemolysis, cold hemolysin related or paroxysmal cold hemoglobinuria, fine? Perfect. Then the routine ones. Though we don't see them often, though we don't read them often, as much we have to read hemolytic anemia, IDA is by default the common one, right? Fatigue, menorrhagia as a history, never ever forget it, koilosnikia, and microcytic hypochromic anemia. A question to you guys, again I want you guys to answer. Tell me what will happen to RDW and what will happen to Mensters index in case of an iron deficiency anemia. Will it be more? Will it be lesser? This is not an entire lecture. I'm just talking about the keywords. We'll go to the lecture one by one soon. Fine. Okay. RDW will be wider and Mensters index will be more than 13 in case of iron deficiency anemia, right? Koilosnikia is one of the important clue for an IDA, right? Then B12 and folate. B12 and folate is always a very close differential diagnosis, be it in an MCQ exam or an university exam. Please be very, very careful on the clinical history because there will be overlapping microscopic findings. Hypersegmented neutrophil will be seen in both. Macrocytosis, macroovalocytosis will be seen in both. But one of the most important finding is your neurological defects. Right? If there is no neurological defects, you will think of folate. A reasoning why question. Can anyone comment why there is no neurological defects in folate and why do we have paresthesias or the subacute degeneration of spinal cord in case of a vitamin B12? Anyone? Okay. This is a very important clue to differentiate between the two causes of megaloblastic anemia. Rest of them is common for both. Macrocytic anemia, hypersegmented is common for both, right? And here, a poor diet, which is having less amount of fruits, is also a clue for folate deficiency, and vegan diet is a clue for vitamin B12 deficiency. Do remember them, right? The right answer for the questions he asked, very simple. Paresthesias are there because B12 is very, very important for producing sphingomyelin or myelination. When B12 is not there, myelin cannot be produced, myelination will not be there, which results in spinal cord degeneration, right? Perfect. Now, aplastic. Any feature suggestive of pancytopenia. Okay, and the most important is dry tap. On aspiration, I have a dry tap and I have a hypocellular bone marrow, which means bone marrow is filled with what? Fill in the blank. What will be bone marrow filled with in case of an aplastic anemia? Anyone? It will be replaced by a useless tissue which will look a lot clear in the microscopy. That's fat. Diagnostic of an aplastic anemia, right? With respect to all these are RBC disorders. We'll read in detail about each and every of the RBC disorders soon. Next is about your bleeding disorders. See, bleeding disorders, not so mainstream. I'm not going to talk about hemophilia, which everyone knows, right? Classical hemarthrosis, factor 8, factor 9 being reduced, I think of in hemophilia. ITP is much more common than hemophilia, fine? ITP, child can have ITP, at the same time middle-aged person can have ITP. Post-viral, post-dengue, it's also considered to be an ITP only, right? It's a short limiting, right? Acute ITP. In women who are having prone to autoimmune disorder, they also have ITP. That's a chronic ITP, right? Isolated thrombocytopenia, one of the most important thing. This is very, very classical, right? Splenomegaly will not be there in ITP in spite of the platelets being destroyed in the spleen. Very, very important. And you will have more amount of megakaryocytes in the bone marrow, right? Can anyone tell me what will be the peripheral smear finding for ITP in case of peripheral smear finding in ITP? What will happen to the platelet morphology? MCQ, Viva question, very important, right? Anyone? Saurima, Riddhi, Siddhi, Praveen, anyone, right? As a very classical finding, you will see classically giant platelets in ITP. Okay, giant platelets in ITP is very, very classical because of a premature release of platelets, as we've seen any case of destructive disorder, right? When I destroy RBC, I prematurely release reticulocyte. When I destroy platelets, I prematurely release giant platelets. As simple as that, right? Perfect. HIT. You are talking about heparin-induced Valikar. Okay, then Bernard-Solow and Glanzmann might not come in a long answer question, might not come in a short answer question. The only thing which can come is an MCQ, right? MCQ you should know, in Bernard-Solow you'll have a defect in one of the glycoprotein. In Glanzmann you'll have the defect in the other glycoprotein, right? Here you'll have defect in GP1B9, a very important 1 mark question or a Viva question. Here you'll have a defect in GP2B3A, right? They don't have classical clinical features. Petit K might have bleeding a little bit in the internal organs, right? One of the important thing, you might have mild thrombocytopenia and Bernard-Solow. Here platelet count will be normal, bleeding time will be elevated because of a platelet defect by default, right? Perfect. Last but not least, von Willebrand. The most common inherited bleeding disorder is von Willebrand disorder. Never forget that. It has come multiple times in a NEET PG exam. So if it comes in NEET PG, there's a very good chance it might come in an MCQ for you also, right? Menorrhagia is by default the most common presentation because autosomal dominant is the most common inheritance. Later in life, bleeding after trauma. Of the two genders, one gender have trauma consecutively every month, right? So menorrhagia, one of the classical presentation of von Willebrand disorder. Von Willebrand, type 1 is most common. This is more of theoretical part. We'll see them later, right? Okay, let's zoom out. So these are the important diseases what you're going to see in today's lecture with respect to RBC and platelet disorders. Are you guys ready? Let's go. We'll have 10-15 minutes of just a superficial understanding of the disease first. Then we'll go a little bit detail on how to write the exam. Then finally, there'll be a fill in the blanks where you'll have a case scenario, and I want you to tell me what is the right diagnosis, right? Perfect. Let's start. Okay. See, all these are going to be one slide, that's all. So the purpose is very clear. Before going to an exam, if you want to swipe through all the RBC disorder, 15 slides is more than enough for you to understand. Same for WBC, same for quite a few organ systems as well. Just 15 slides, go through it, you'll have most of the information ready here, right? Okay. Hereditary spherocytosis is an autosomal dominant inheritance. Most common again. Because I do have recessive inheritance also. If you remember hereditary spherocytosis, it's a problem in the RBC's membrane. If you draw RBC membrane here, if you're good artistical, draw an RBC membrane, draw proteins here, name them band 3, your protein ankyrin, okay? Your protein, there are a few more bands, right? Band, and then you'll have spectrin, which is a helical protein. So all these are RBC's membrane disorder. If you have a problem in any of the protein in the vertical interaction, that's what I mentioned here. When you have a problem in the proteins in the vertical interaction, you will end up in having a hereditary spherocytosis, right? That's not the right approach, but as the time is limited, please use this as maximum resource, fine? So Tomic, okay? So any mutation in the vertical interaction protein will result in a hereditary spherocytosis, right? And the most common mutation, anyone, can you answer the fill in the blanks? These fill in the blanks are exercises for you. I'll tell you exactly what to read before the FARRE, read that and come in the notes, and revise, use this as a revision, right? The most common by default is an ankyrin. Ankyrin mutation is the most common. They are not very severe disease, but there's a possibility for me to have a very severe disease also. Can anyone tell me what's the most severe type of mutation? Which mutation will result in severe hereditary spherocytosis? That is spectrin mutation. Spectrin is severe for the only reason spectrin is inherited in autosomal recessive inheritance. Because autosomal recessive, you'll have two mutations, right? Both the allele are gone. Zero spectrin, obviously more severe, right? That's the reason it's more severe. You know the reason also, right? Now, if the vertical interaction is gone, see, what's the shape of RBC? Anyone? Before going to the pathogenesis flowchart, just a simple question for you guys. Everyone online should comment. This is the easiest question which you're reading from 6th standard, right? What's the shape of an RBC? RBC is a biconcave disc-shaped structure, right? So someone is pulling the RBC like this and keeping it. That's the vertical interaction. The proteins in the membrane are pulling it like this. So when the proteins are gone, this pull effect is gone. So what happens? It becomes spherical, right? So simple. So when the proteins or the vertical interaction are gone, they automatically become spherical. That's all is the pathogenesis. Very, very simple pathogenesis. So once the proteins become spherical, they will be trapped in the splenic sinusoids. Because you remember, in spleen, they have to go narrow through the sinusoids. In the old edition of Robbins, there'll be a beautiful explanation for this. It's like an elephant trying to squeeze through a door. You can't squeeze through it, right? Because they're round, they're rigid, they can't squeeze through it, right? So this will get trapped inside the splenic sinusoids. The moment it gets trapped inside the splenic sinusoids, who are there? Every sinusoid in the body will have macrophages, littoral cells. If you want to write littoral cells, show it off to the examiner. See, I know the macrophage name of the spleen also. They eat them, they destroy them. So what type of hemolysis? Intravascular, extravascular? I should have hidden this. What type of hemolysis? They get caught inside, the littoral cell will eat them. That will classically cause extravascular hemolysis. I'm going to ask you one more question. Let's see how many of you guys answer. If there's an extravascular hemolysis, will the patient have hematuria? Yes or no? It's a classical case of extravascular hemolysis. Very simple pathogenesis. In an exam, theory exam, no one wants you to write the perfect one. A simple flowchart for pathogenesis is more than enough, right? You will not have hematuria in case of extravascular hemolysis. Intravascular, when leaving the blood, RBC dies inside the blood vessel, it will go to the kidney, you'll have hematuria. Here you won't have hematuria, right? See, now let's come back to this. Most common is autosomal dominant inheritance. Presence early in life or later in life. That's my clinical feature. Etiology done, pathogenesis done, clinical feature. They will present during adults. You will have low-grade hemolysis only because one allele is normal. Dominant is only one mutation. So other allele will still contribute to ankyrin. band 4.2, band 3, everything it will contribute, right? So low grade hemolysis, but I'll have gallstones. And it will be particularly pigmented gallstones. A reasoning why question. Why do you have pigmented gallstones in case of hereditary spherocytosis? What is the reason? Simple. What's the reason? It's because of increase in your indirect bilirubin. That's all. Due to increased amount of your unconjugated or an indirect bilirubin is the reason. So unconjugated bilirubin increases, and this unconjugated bilirubin over the period of years accumulates in the gallbladder and produces pigmented gallbladder calculi, and splenomegaly will be there. Anemia will not be the presenting feature. Pigmented, right? Pigmented gallbladder calculi, splenomegaly, adult. This triad is enough for me to call it an hereditary spherocytosis. What will I see in microscope? Very simple finding, right? I'm going to see spherocytes in the microscope. In peripheral smear, you'll see spherocytes. How do you identify spherocytes? My normal RBC was like this. Now it has become circular. When it becomes circular, first is it will become smaller because someone was pulling it, right? No one to pull, becomes smaller. Smaller RBCs, they have become spherical RBCs, right? And there'll be no central pillar. Very, very classical, because when it's a biconcave disc shaped structure, again reasoning by question, the hemoglobin will be towards the periphery, right? Disc. In the center, there'll be no hemoglobin. Now, there's no biconcave structure, so entire RBC will become fully hemoglobinous, right? So smaller, darker, no central pillar is diagnostic of spherocyte. Never ever forget this three combination. Anywhere in exam, this three combination comes, think of spherocyte. Now, can anyone tell me what's the most common cause of spherocytosis? Because that will take us to the next direction. What is the most common cause of spherocytosis? The most common cause of spherocytosis? Autoimmune hemolytic anemia, right? Cannot deny that at all. The most common cause of spherocytosis can come in one liner is autoimmune hemolytic anemia. So whenever you see spherocyte, I don't jump into hereditary spherocytosis. We do Coombs test to rule out the most common cause. Clear? I have to do Coombs test to rule out the most common cause. Fine. CBC is by default an important investigation. If you want to extend the pages, right? Okay, hemoglobin will be reduced, WBC will be normal, platelet will be normal. If you don't want to talk bullshit, just go to the important point. With respect to your MCV will be normal in hereditary spherocytosis. The most important thing for me is MCHC. MCHC will be elevated. If a question comes in reasoning why, right? I'm going to put a question. Can anyone tell me why there's an increased MCHC? It's the same amount of hemoglobin, but a slightly less volume of spherocyte. Smaller, darker, and no central pillar, right? Dark, right? That's the reason I have more MCHC. Mean corpuscular hemoglobin concentration increases. It's an important MCQ point. Don't forget that, right? Okay. First thing I have to do this. Whenever you see a spherocytic anemia, do a Coombs test to rule it out. If Coombs is negative, only then I think of HS. Otherwise, I don't think of HS, right? I don't think of HS only then, right? So I do an osmotic fragility test. I am not a fan of osmotic fragility test. You know that, right? Osmotic fragility test. Can anyone tell me what will be the features seen in osmotic fragility test for spherocyte? Just one word. What will happen to spherocyte in osmotic fragility test? They'll be osmotically more fragile or less fragile? More or less. That's enough for me. They are smaller. They are rigid RBCs. That's why they cannot squeeze through the splenic sinusoids. Now they are rigid RBCs. So what will happen if they are swollen? They will rupture. Spherocytes are osmotically fragile. They are osmotically more fragile cells. Again, might not give me extra clue than what I see in peripheral smear. Spherocyte, that's all. Right? If Coombs is negative, the investigation of choice is EMA flow cytometry. Eosin 5 maleimide. It binds to band 3. Where was band 3? Here is band 3, right? The topmost guy. If it binds to band 3, it's present in a person's blood, which means entire building is present. No HS. If it's not there, the stain is not there, which means any one of the components of the building is absent, which is diagnostic of HS, right? So diagnosis binds to band 3. If band 3 is negative, any one of the vertical interactions is abnormal. Here, this is your HS diagnosis. If band 3 is positive, it's a normal RBC, completely fine. The patient is completely normal, right? Just to complete, since you're in the fag end of the second year, you should know a little bit about the treatment, right? Can anyone just fill up the treatment? What do you think, or how do you treat hereditary spherocytosis? If I diagnose them as HS, what's the treatment? Treatment is simple. The problem is in the RBC, but where it's getting destroyed? It's getting destroyed in the spleen. The only way I can treat it, I remove the spleen, right? You remove the spleen. Splenectomy is the way of treatment. Again, if you want to increase it, right splenectomy along with vaccination for capsulated organisms. Integrate microbiology. Because spleen, once it's removed, you'll have more risk for infection with capsulated organisms, right? I'm going to zoom out. This one slide will give you all the information required for hereditary spherocytosis, right? Just read them, revise them, go and write beautifully in the exam. Presentation is in your hands. If your handwriting is not great, it doesn't matter. Present properly. That's more than enough for you to get a good mark, very good mark in a theory exam. Fine. That's the first disease. Can we go to the second disease? Before going to second disease, I'm going to ask you a few questions. I want you guys to answer. Let's see how many of you get the right answer. The next disease I'm going to talk about is G6PD deficiency. Can anyone tell me the inheritance? Simple questions. You guys will definitely know. Don't be shy. If it's wrong, it's wrong. Doesn't matter. We know that, right? What's the inheritance? Inheritance is X-linked recessive, right? If G6PD is deficient, which pathway in the RBC, biochemical pathway, will be affected? Is it glycolytic pathway? Is it some other pathway? Which pathway will be affected? If G6PD is absent, you'll have hexose monophosphate pathway will not be proper, right? If hexose monophosphate pathway is not proper, what will we lose? Will we lose ATP, ADP, GDP, NADP, NADPH? What will we lose? We lose perfect NADP, NADPH. So if I lose NADP, NADPH, what is a big deal? What recycling will not happen properly? What recycling will not happen properly if you lose NADP, NADPH? Very simple, superb. The glutathione recycling, right? I need glutathione because they are the most important free radical scavengers for me. So in simple process in G6PD deficiency, I'm going to have more amount of reactive oxygen species induced damage to the RBCs. That's it, right? Okay, let's go. Same thing. I'm going to have glucose 6-phosphate deficiency. Like you guys exactly said, it's an X-linked recessive inheritance. Who's more commonly affected? Men or women? Any X-linked recessive? You'll have men being the affected person, women being carriers, right? Normal function of G6PD, normal HMP pathway, NADP, NADPH is completely normal. If I have a G6PD deficiency, right? Here I'll have reduced recycling of glutathione peroxidase. Because of that, I'm going to have increased exposure to reactive oxygen species. Write in the form of a bullet point or put in the form of a flow chart. Whatever is comfortable for you, do that, right? So ultimately, RBC will have destruction by reactive oxygen species. We'll go to general pathology. Lipid peroxidation of cell membrane, protein denaturation, DNA damage, right? Now a very important question, reasoning why. See, wherever we are going to read for FARRE, I'll give you clues which can come for reasoning why from my perspective. G6PD is an inherited disorder. So I'll have problems in RBC, WBC as well as platelets. So why is RBC alone lysed? WBC and platelets are not being destroyed in G6PD deficiency. A very important reasoning why question. Answer is simple. Because RBCs do not have a nucleus. I am thoroughly dependent on recycling. Right? WBC and platelets might have nucleus and nuclear fragments so that I am born with that, right? So I can produce new one, right? So they are not totally dependent on recycling, unlike RBCs, other blood cells. That's the reason WBC and platelets are not being affected. A very important reasoning why question, right? Perfect. So now we know what is the problem. Now let's expand the pathogenesis, right? So here I'm going to have RBC destroying the platelets, reactive oxygen species destroying the RBC's membrane by lipid peroxidation. If you have maximum amount of RBC, reactive oxygen species, maximum destruction to the membrane, which will result in rupture. Once the RBC is ruptured, I'll have intravascular hemolysis. Will this cause hematuria? Yes or no? Everyone, answer yes, no. Just yes or n. That's more than enough. Intravascular hemolysis will definitely result in hematuria. Okay. If the reactive oxygen species is subtle, not that high, little bit elevated, I cannot rupture the membrane, but I can weaken the membrane. The moment it weakens, the force goes off, right? So it will become a spherocyte. This will cause extravascular hemolysis, same like your hereditary spherocytosis. That's all, right? Perfect. Now, so this is what is going to cause. And if there's an MCQ, which is more important for G6PD deficiency, definitely intravascular hemolysis is more important than extravascular hemolysis because this happens after fever. In fever, I will never have less reactive oxygen species. I'll always have more reactive oxygen species, right? So that's what's going to happen here, right? Next of the reactive oxygen species, protein denaturation. The protein has been destroyed. What is the most common protein which comes to your mind in RBC? Hemoglobin. Globin is being destroyed. So you'll have denatured globin. What will any protein destruction, if I destroy a protein, what will happen to a protein? Right from your undergraduate days, first year, biochemistry, you destroy a protein, it becomes a coagulum. It coagulates. So this denatured protein also coagulates and settles on the membrane. See, everything will coagulate and everything will settle on a membrane, right? If it coagulates, it will automatically come down, it will sit close to the membrane. That settled denatured protein is your Heinz body. The inclusion body, which can be picked up in, someone told in the start of the lecture itself, in new methylene blue stain, right? Classically can be picked up in new methylene blue stain. It can be seen only in new methylene blue stain. That's the reason when I do a Leishman stain, can anyone tell me what is the appearance? This cannot be seen in Leishman stain. So, in a Leishman stain, the RBC coagulum is not seen. When they are not seen, I'll end up in having an empty space which looks like a bite cell. The reason for your bite cell is not able to see the RBC coagulum. This also can come in a reasoning by question because of the unstained part of the RBC coagulum, we end up in having a bite cell, right? Clear? Perfect. Done. So this is the pathogenesis. I don't mind about the third problem of reactive oxygen species because I don't have a nucleus here. No nucleus, no destruction at all, right? Perfect. Now, clinical history. You know the clinical features. Mostly in men because of X-linked recessive inheritance. It doesn't matter, but you want if you write. It's a trigger-based hemolysis. Undoubtedly, you should have this. Could be an infection, could be drugs. These are the two important drugs I want an undergraduate to remember. The moment you go and open Harrison, there'll be an entire page of drugs. I cannot remember everything. At least remember Primaquine, Dapsone, right? Then fava beans. Fava beans, particularly in few parts of the world where they consume it regularly in the diet, they can have it. It's always trigger-based hemolysis. Since I told intravascular is more important than extravascular, you will have definitely dark colored urine. That's a classical finding for dark colored urine, right? Yes, Walikar, Robbins is wrong. I told in the lecture, Robbins is not updated. They'll update it hopefully soon. Fine. Okay. So dark colored urine, hematuria is a classical finding because of intravascular hemolysis being more, right? So peripheral smear finding, we already know because we read the pathogenesis, na? Bite cell, can I see spherocytes? Yes or no? Comment, it's fine if you go wrong. Can I see spherocytes? Yes or no? Definitely Leishman stain, I will see bite cells. There's no doubt in that. Will you be able to see spherocytes? Obviously, yes. So spherocyte seeing is not equivalent to spherocytosis. Almost every hemolytic anemia you will see that. Please don't make the mistake. I saw spherocytes in the exam. I'm going to write spherocytosis. You can see them in almost every hemolytic anemia, right? In new methylene blue, obviously I'll see Heinz bodies will be seen. And if you want to add one more, there will be increase in retic count because retic count will be increased in every hemolytic anemia. Not only here, it will be increased in every hemolytic anemia. This is enough for me to diagnose. But if investigation of choice is a heading, right? Simple. It's an enzyme deficiency. Enzyme unless the investigation of choice. Unless the enzyme, automatically you can take care of it. G6PD levels reduced. Diagnosis. That's all, right? How do you treat? Anyone, how do you treat? Then enzyme deficiency. G6PD deficiency. The natural course of mind which comes to your mind is replace the enzyme. Not that easy, right? It's just supportive treatment. What do you mean by supportive treatment? Wait and watch. There's a fever, there's hematuria. Look at the hemoglobin. If it's 10, 11, okay. Because once the fever stops, trigger stops, hemolysis stops. Supportive treatment because of self-limiting disease. The hemolysis automatically will stop the moment reactive oxygen species comes back to normal. And tell the patient, that if you have a fever again, please go to a doctor immediately because you have a condition where it can be destroyed, right? Siddhi, your choice. If you are able to draw a spherocyte like this, draw a bite cell like this, draw a Heinz body like this. Possible to draw. Because see, I don't want you to go and waste putting hundreds of around here. That doesn't matter for me. If you can draw a spherocyte just next to it, you can draw a bite cell just next to it. That's more than enough rather than drawing the entire smear, right? Okay. They know, if you have written it, they know that you will know how a spherocyte looks like. That's all, fine. And obviously stop the drugs. Great, perfect. The next disease, what you're going to go is, PNH, we'll look at PNH later, is about sickle cell anemia. Before going to sickle cell anemia, I'm going to ask you similar questions like I asked for G6PD deficiency. Ready? Starting with inheritance. Can anyone tell me what is the inheritance of sickle cell anemia? That's the first question. I want you guys to answer. It is fine. This is a revision for us, right? In sickle cell anemia, you have in the beta chain, hemoglobin, 6th position, glutamic acid changes to what? That's the second question. First is inheritance. Second is what amino acid will be changed in case of sickle cell anemia. Third question. Because of this change in amino acid from glutamic acid to dash, what will happen to the property of the hemoglobin? That is the characteristic problem in sickle cell anemia. What will happen to the property of hemoglobin? Glutamic acid becomes valine. Glutamic acid is a hydrophilic amino acid. Valine is a hydrophobic amino acid. It hates water. So hemoglobin will become less soluble. If they become less soluble, they clump. That's the problem in sickle cell anemia, right? In sickle cell anemia, we have two types of RBCs formed. Reversibly sickled RBCs, irreversibly sickled RBCs. Which of these RBCs causes vaso-occlusive crisis? Great. Great, Dr. Future. Low oxygen tension promotes that. You're absolutely right. Which of these will cause vaso-occlusive crisis? The reversible sickled RBCs cause vaso-occlusive crisis. The irreversible sickled one predominantly goes and gets stuck in the spleen and they'll be destroyed. That's all. If reversible sickled RBC is going to cause all the vaso-occlusive crisis, can anyone tell me a drug which is used to reverse this condition? It's reversible, right? So obviously I must have a drug. Can anyone tell me a drug? That's a treatment for sickle cell anemia. A very simple drug. It's hydroxyurea, right? Great. Okay. Now let's go to sickle cell anemia. Same one sheet, all the required information for sickle cell anemia. Ready? Okay, let's go. So sickle cell anemia, it's an autosomal recessive inheritance. Here you have point mutation, beta chain, 6th position. I will stick to 6th position. I am not going to the controversy of 6th to 7th position. Fine. Here, the glutamic acid becomes valine, which is hydrophobic. So I have HBS. Same thing, if glutamic acid in the same position becomes lysine, which causes HBC. In HBC, you will see HB hemoglobin crystals. It will crystallize. The hemoglobin crystallizes. That's a problem with HPC. It's a different hemoglobinopathy. Fine. Because of this change, what will happen? You will have less solubility, like you guys said. Hemoglobin becomes less soluble. Hemoglobin forms clumps. And this is accentuated by low oxygen in the hemoglobin, right? It will accentuate the clump formation. Someone even commented on that, right? Then it will damage the membrane, causes reversible sickled RBC. Low oxygen causes the sickling. So when I give oxygen to it, it will reverse back. So when oxygen is present, it will become back a normal RBC. And this cycle will keep on going till we have deoxygenated state. So the moment your RBC loses oxygen, it will become a sickle again. Moment it gets oxygen, it will become normal again. It will keep on doing this. But everything will have an end point, right? At some point of time, your potassium, your water will go outside, your calcium will come inside, causing more membrane damage and resulting in irreversible sickled RBC. This irreversible sickled RBC commonly gets stuck in the spleen, right? And they cause extravascular hemolysis. That's the common. Very rarely, the membrane damage is so severe, it can also cause intravascular hemolysis. This is purely theoretical. Why I'm telling it is, sickle cell anemia will not have hematuria. But if theoretically an MCQ is asked, yes, extravascular, little bit of intravascular can also happen, right? Purely theoretical, in real life it does not happen, fine? So this is the pathogens of sickle cell anemia. Now, you guys only said that this is very, very important for me. The oxygen status, which means there are some factors which will promote sickling. There are some factors which will reduce sickling. Can anyone tell me few factors? We'll definitely go into it. At least one factor which will promote sickling or reduce sickling, except for oxygen affinity, the oxygen concentration. The first is the amount of sickled RBCs, amount of sickling, right? Homozygous, both are mutated, I'll have more sickling. Heterozygous, one is normal, one is mutated, less sickling. That's the first one, right? Obviously, homozygous have more sickling, right? Heterozygous generally will have approximately 40% of HBS, will have less sickling, approximately, right? Perfect. See, HBSC or HBCS, right? Sickling will be less than HBSS, but definitely more than normal heterozygous hemoglobin. And it's very, very important. This can come in an exam, can come in an MCQ. Remember, hemoglobin SC disease or CS. One is C, one is S, has more incident of sickle cell retinopathy. There's a classical finding, do remember them, fine? And obviously, it's the order of sickling. HBSS, then HBS and HBC, then HBAS. AS is your heterozygous sickle, right? Then, like I said, more oxygen tension, so oxygen concentration will reduce sickling, right? So, in venous blood, in stasis, in inflammation, in all these places, I'll have less oxygen concentration in RBCs. More time an RBC stays with the tissue will suck the oxygen, right? So automatically oxygen reduces inside the RBC, promotes sickling. Inflammation, you'll have stasis, right? Whatever you said is right. pH, again, will be a problem during inflammation, okay? Reduce MCHC. Well, see, when MCHC reduces, I have more space there, so it kind of reduces sickling. Fine. That's why if I have hemoglobin plus alpha-thalassemia, alpha-thalassemia means alpha chains are absent, so I have more space there, right? So that also reduces sickling, right? Because of reduction in MCHC due to reduction or absent alpha chains. Normally it is A and B, alpha and beta. Alpha is gone, I have more space, so kind of the oxygen affinity will be split. Instead of 4 chains, it's going to be split towards these two guys, right? So it definitely will reduce sickling. Though not an important thing, these two are very, very important for me. The amount of hemoglobin S determines the episode of sickling, and the amount of oxygen present, especially in venous circulation, stasis, inflammation, is going to promote sickling. Reduce oxygen, reduce sickling, right? Perfect. So we know the pathogenesis, we know what is going to promote sickling. So what do you see in the clinical features? Clinical features diagnostic. We saw the clinical features, right? Irreversible sickle RBCs leads to only one thing, leads to anemia. They don't have any problem at all. The only thing which is it will get destroyed in the spleen. But reversible sickle RBCs, because of the repeated membrane injury, they become more sticky. In addition to the inflammation, right, they will go and stick to the endothelium. So draw a blood vessel, draw sickled RBCs getting piled up one after the other, which will block the tiny vessels. It might not block an iota, not possible, right? It can block a tiny vessel, an artery, arteriole, a capillary, it can definitely block. I'm just writing capillary, but you can write this tiny vessels. So the moment the capillaries are blocked, you'll end up in having vaso-occlusive crisis. Dr. Future, it will be available in the PW Telegram group, or you can ping me here. I'll add you to the WhatsApp group. I'll create one more WhatsApp group. I'll add there and I'll put the PDF there. Fine. Okay. So you'll have vaso-occlusive crisis, right? So the most common vaso-occlusive crisis, dactylitis. Please remember, if you have a patient in India, in Gujarat, Bihar, Northeast, or your Orissa, these places, Kolkata, these are very, very common belt for sickle. Digits pain, think of sickle cell anemia, vaso-occlusive crisis, because that's the most common presentation, right? Chronic non-healing ulcer, right? As the vessel is occluded, there will be no granulation tissue. That's why non-healing. I'll have a destruction of the epithelium because of ischemia. When it heals, I need granulation tissue. Granulation tissue is nothing but capillaries. That also will be blocked. It cannot heal, right? Priapism, because you know that penile engorgement is a vascular phenomenon by the corpora generally. But here, the RBCs blocks and result in the engorgement of the penis. Again, a very common presenting feature in men. More than half of men present with priapism for sickle cell anemia, right? Autosplenectomy, an MCQ point, due to recurrent tiny damage, right? Due to recurrent tiny splenic infarcts, it will result in disappearance of the entire spleen over a period of time. It will not happen in a day or two, right? Acute chest syndrome is one of the most severe condition due to blocking of the lung capillaries. Generally, lung capillaries will not be blocked. Why? That's where I have the maximum oxygen, right? But in very rare cases, if lung capillaries are only blocked, can't do anything. Presence like MI, mimics like MI, DD is MI. Treatment is have 100% SpO2, maintain 100% saturation, give oxygen till it becomes 100%. It will automatically reverse, come back to normal. Or if it doesn't work, you have to go on with an exchange transfusion. Give a new blood. So that sickle is not there, I introduce a normal blood, so automatically it goes away, right? So that's your vaso-occlusive crisis. That's how most of them will present. Here, in the clinical features, I have not even mentioned anemia because anemia is not the primary presentation of sickle cell anemia. It's a pain which is the primary presentation. Fine. Okay. How do you diagnose? Peripheral smear findings. Come on. Your turn. What will you see in the peripheral smear? Anyone? Not a difficult thing. Like I'll tell sickle cells. I want you to tell the other name of sickle cell. Someone even commented on that. Walikar commented on that. What's the other name of sickle cell? I'll see them in microscope. Right. I can see spherocyte. Like every hemolytic anemia, you will see the sickled RBCs. And also you might see target cells. Not often, but possible to see target cells, right? So if it's a heterozygous patient, okay, 2-mark question or 3-mark question. If it's a heterozygous patient, a carrier state, not readily seeing sickle in microscope, what is a chemical I do to induce sickling? We call them sickling test. What's a chemical we do to induce sickling? Anyone? We put a chemical into the blood which will suck up all the oxygen. Reducing agent, that's all, suck up all the oxygen. So I will push the normal RBC to sickled RBC. Sickling test, what's a chemical? Okay, let's see. Fine. So peripheral smear is very simple for me. I'll say sickle cell, drepanocyte, target cell possible, spherocytes possible, but sickle cell is diagnostic. Sickle, please remember, need not always be like this. Tapered cell is also sickle. Flat cell is also considered sickle only. But the original cell is going to be like a sickle, right? You do sickling test by adding sodium metabisulfite, which just sucks up all the oxygen and it will push the RBC to sickled RBC. So 2 hours, within 2 hours I'll have them. Within 24 hours also I can see them, right? You put the drop of blood, seal it with a nail polish so that no oxygen from outside enters. That's all we have to do, right? Perfect. Investigator choice for every hemoglobinopathies, HPLC is better, right? So what you're going to look for HPLC? First, always look for the controls. If HPLC image is given, compare with controls. Okay. If HbA2 is elevated, question to you guys, what will you think of? In a long answer question, the question says HbA2 levels is 5% elevated. What will you think of? If HbF is elevated, what will you think of? What will you think of? This interpretation of HPLC, that also we'll see. You'll think of, always think of thalassemia. If A2 is elevated, the first thought process is thalassemia. Thalassemia minor, because thalassemia major, I won't have difficulty in diagnosing, right? If F is elevated, I always think of severe hemolytic anemia. Every severe hemolytic anemia, my body is not able to take care of it. So it will go for fetal hemoglobin to help me, right? HbF elevated, sickle cell anemia major. So sickle cell anemia homozygous or thal major, alpha or beta thal, fine? Okay, that's important. Do remember. Treatment, HbF, treatment is hydroxyurea because hydroxyurea increases HbF concentration. What will HbF do? HbF will hold more oxygen. Why will HbF hold more oxygen? Because HbF has gamma chains instead of beta, right? Gamma chains only purpose to hold more oxygen. So it will oxygenate the RBC. The moment it oxygenates RBC, it will automatically cause reversal of sickling, right? It reverses sickling. And also it's an anti-inflammatory drug, reduces inflammation. That also will help in the removal of the vaso-occlusive crisis episode, whatever it is there, right? Perfect. So that's about your sickle cell anemia. Everything required for sickle cell anemia in a single flow chart, right? In a single page of a PowerPoint, right? I'll give you this. listen to this and then read them. If you just read them without listening to it, it'll look like a series of information. That's all. Fine. Okay. Now let's go to thalassemia. Are you guys ready for more questions? I'll ask you questions. Same way, let's go ahead and read about thalassemia. Okay. Ready? Okay. I'm not going to ask about the inheritance of thalassemia because you guys know the inheritance by default. It's autosomal recessive, right? So tell me, in case of beta thalassemia major, right? What is the problem? What results to symptoms? Absence beta chain or excess alpha chain? What result to symptoms? Absent beta or excess alpha? It's going to be excess alpha chain which causes symptoms in thalassemia major and not absent beta chains, right? Okay. In case of thalassemia major, the patient will present at birth or after 3 to 6 months or later in life. What do you guys think? That's the next question. In case of thalassemia major, there's a classical face appearance. What's the name of the face appearance? What's a classical face appearance for thalassemia major? Okay, that's the next question I want you guys to answer. Thal major also I'm going to diagnose with HPLC only. In case of Thal major, what will happen to the hemoglobin F levels in HPLC? Will it be high? Will it be low? Go ahead, Akash. See you soon here. They will present around 3 to 6 months because you will have till then hemoglobin F which will compensate. The classical phases name is chipmunk phases, right? Or hemolytic phases because the prominent bony prominence and everything you'll have that, right? Perfect. Great. If in case of Thal major, in HPLC, hemoglobin F will be very highly elevated because of severe hemolytic anemia, right? Let's go to Thal major. There are few reasoning why questions in Thal major. I'll definitely talk about them when we come to it. Just a single slide for all the important information for Thal major. Let's zoom in. Thal major is an autosomal recessive inheritance. Obviously, it's due to mutations, right? There are two things in Thal major. In Thal minor, I have reduced synthesis. In Thal major, I have no synthesis at all, right? What are type of mutations? I can have beta 0, I can have beta plus. Beta 0 means I don't have any beta globin chain produced. Beta plus is I have some chain production but not normal. Beta plus predominantly is promoter gene mutation. This is Indian data. Okay. In beta 0, I have one thing. This I want you to remember IVS, that is intervening segment or intron. In the intron 1, 5th position, G becomes C. Okay, that's the intervening sequence. In the intron 1, this is approved for prenatal diagnosis. This also is approved for prenatal diagnosis. 619th base pair deletion. These two are very common in India, approved for prenatal diagnosis. Don't forget them, please. Okay, because Thal major is becoming a huge problem for us and we have to know what's going to happen in India. This is Robbins data, the world data. Fine. Beta 0, most common is chain terminator. Beta plus, the most common is splicing mutation. But in India, the data is a bit different. Fine. So whatever happens, India or the world, pathogenesis remains the same. So like you guys said, the problem is never reduction in the beta chain. The problem is always has excess alpha chain. If two chains are lost, what will happen? You will have be replaced by 4 alpha chains. 4 alpha chains is actually the problem. This excess alpha chain is actually the cause for all the symptoms. Okay, because that's what is going to trouble the blast. So in the proerythroblast, the beta chains will be replaced by 4 alpha chains. If there are 4 alpha, these 4 alpha forms a clump. Whenever there's clump in the RBC or in the proerythroblast, it will damage the membrane. The only difference is here, the damage happens inside the bone marrow. In sickle, in G6PD, in HS, damage happens in the peripheral blood, right? So it's much more severe, that's all, due to the alpha chain forming clumps. Okay, I'm going to get destroyed. If the blast is destroyed, what will bone marrow do? Will it respond by producing more hyperplasia? Undoubtedly, yes, right? So the response will be more or less, it will be very, very high. You will have marrow hyperplasia without a doubt, right? But what happens is, in spite of having marrow hyperplasia, half of them will die and half of them what is formed will be deformed. Okay, so I want you to answer a question, listen carefully and then answer. in spite of having 8 to 10 times bone marrow hyperplasia, my body is not able to correct the anemia. What is the name given to this process? I'm having so much amount of bone marrow hyperplasia. In spite of that, body is not able to correct anemia. What's the name of this process? It's a simple name. What's the name? That is perfect. In spite of this, the body will fail to correct anemia. And this is called as an ineffective erythropoiesis. Very, very important. Ineffective erythropoiesis can lead to two more reasoning why questions. Because of ineffective erythropoiesis in the bone marrow, what will happen to the spleen? Will they contribute to hematopoiesis? Yes or no? Obviously, they'll contribute to hematopoiesis. Will they be able to correct? No, because the problem is in the blast, not in the bone marrow, right? Because of that, what will happen? You will end up in having splenomegaly. Okay, this is a very, very important question. This is due to extramedullary hematopoiesis. It's a very important reasoning why question. Splenomegaly normally is seen in extravascular hemolysis. In thalassemia, there is no extravascular hemolysis. The hemolysis happens in the bone marrow, intramedullary. In spite of that, you have splenomegaly because of extramedullary hematopoiesis. Important. Since the patient is having ineffective erythropoiesis, you will have very moderate elevated retic count. Retic count will be in the range of 2 to 3, right? Anemia will be very severe. It will not increase the retic as proportional to the anemia. Fine. Sorry, I just answered the question. It's due to extramedullary hematopoiesis. There's a reasoning why question which can come here, right? So whatever is happening in the bone marrow is forming deformed blast. The deformed blast will be smaller. That's the reason I'm having microcytosis. The deformed blast can be irregular. That's the reason I'm having poikilocyte. I'm having target cell. All these are deformed RBCs only. That's all. Right? These are abnormal RBCs. Fine. So that's what is going to be the pathogenesis of Thal major. Alpha thalassemia major, they might not ask you. If they ask you, pathogenesis remains the same. The only difference is instead of alpha chain, beta chain. That's the only change you'll have to make, right? Perfect. Now, let's go to the diagnosis. We have major, we have minor. Let's go on how to diagnose. Presence in and around 6 months of age. Because till 6 months, hemoglobin F will be present, alpha to gamma to no beta. Obviously, no disease percentage, right? Around 3 months, the disease presentation slowly starts. The patient presents with failure to thrive. Failure to thrive means the kid will not grow. The kid will not have the developmental milestones. You must have gone to pediatrics age group, right? In the presentation, you must have said gross motor, fine motor milestones will not be developed because the kid is not able to grow. Classical phases, chipmunk phases or hemolytic phases. Prominent frontal bone, prominent zygomatic arch. I'm just going to add one more finding. I want you guys to tell the answer. Can anyone tell me what is the X-ray finding in this patient? The lateral view of X-ray finding in the patient of your skull. There's a very classical appearance. This also is seen in every severe hemolytic anemia, including thalassemia, right? I want you guys to comment. We'll go to the next. I'll come back to this soon. Fine. So what will be the CBC finding, right? We have a template to fill it up. That's all. MCV will be reduced. MCHC will be reduced. Hemoglobin will be very, very low, right? Hemoglobin will be less than 7 gram percentage in most of the patient. That's why failure to thrive. Hemoglobin is 7. The kid cannot survive, right? Because for everything in my body, we need the hemoglobin. Great, guys. Hair on end appearance or the crooked appearance is the X-ray finding in the lateral view of skull, right? Peripheral smear, you'll have microcytic RBCs. This need not, please don't write this in an exam, but it's important. If it's a viva, how it's microcytic, smaller than the nucleus of the small lymphocyte. Hypochromic, how it is hypochromic, more than 1% central pillar. 1/3 central pillar. If you want write, but not required here, right? Target cells are diagnostic. Okay. Even if you forget microcytic hypochromic, I don't want you to forget this. Late normoblast or NRBCs. This is classically seen in Thal major. Thal minor will not have NRBC in peripheral smear. Only Thal major will have. So it's a difference seen only in Thal major, not in Thal minor. So it's important for me to understand that. Fine. Okay. Perfect. You guys said it's your crew cut appearance of skull or your hair on end appearance of skull. Okay. Investigation choice is by default your HPLC, right? Walikar, you are right about Menster's index. I'm not commenting, but I don't want Menster's index because this is not a differential diagnosis for IDA. IDA very unlikely to present 3 years age, 3 months of age, 6 months of age. IDA will not go to 7 gram. Very, very, very unlikely. So I won't want Menster's index here. But you are absolutely right. Okay. HPLC is definitely better than hemoglobin electrophoresis. So what do I have in HPLCs? There will be no hemoglobin A. Hemoglobin A is adult hemoglobin nil because no alpha to beta 2 and excess amount of hemoglobin F. Hemoglobin F will be around 80-90%. That is diagnostic of thalassemia major. No hemoglobin A, diagnostic of thalassemia major, right? That's enough for us for diagnosing. Actually, bone marrow examination required or not? What do you guys think? Bone marrow examination is not required, but I don't know, for some reason, quite a few universities across India has asked what is a bone marrow finding of thalassemia major in a 2-mark question. I don't know why they want you to learn. It's fine. It's our unfortunate fate to learn things which are not important, right? Bone marrow findings are not required. If there, you will have erythroid hyperplasia. Obviously, I'm going to have destruction in the periphery. I'll have excess amount of hyperplasia in the erythroid. Bone marrow will be by default hypercellular. A hypercellular bone marrow with erythroid hyperplasia. Only one MCQ point has been asked long back. They have stopped asking because it's an irrelevant investigation now, right? You have a structure called as sea blue histiocytes. These are nothing but macrophages which are bluish in color, or we also call them pseudo-Gaucher cells. Okay, pseudo-Gaucher cells or sea blue histiocytes is a classical finding seen in, not in thalassemia, is seen in any condition where bone marrow divides more. That's all, right? General, I don't require bone marrow. It's not required, but if there's a 2-mark question, what will you see in thalassemia major? Please don't worry. If you heard anything which is not required in real life, you're not read before, don't worry about it. Think for 2 seconds, you'll know the answer. Right? I'm having a problem in the RBC. RBC is destroying, bone marrow becomes hyperplastic. Which part of the bone marrow? Erythroid by default. And sea blue histiocyte is an additional finding which might be required, right? Perfect. How do you treat? Treatment is simple. The best for me is bone marrow transplant, if I can give. But match everything is difficult. Otherwise, repeated transfusion plus iron chelator. You know pharmacology also, so don't miss the name. Deferriprone or deferricerox is better. If you don't remember the oral iron chelator, desferrioxamine, that also is fine, right? But they are definitely transfusion dependent. They have to be transfusion dependent without a doubt. Okay, perfect. Just a few words about Thal minor. Thal minor is a very close differential diagnosis of IDA. Instantly diagnosed, hemoglobin in the range of 11 to 12, right? This is how we differentiate Thal minor from IDA. Here it's very important. Thalassemia, right? We read thalassemia, right? Normal RDW, or it could be sometimes even a narrow RDW, less than normal, and less than 13 Menster's index. IDA, more than 13 Menster's index, and increased RDW. That's how we differentiate, right? Peripheral smear will have target cells. Again, a question to you guys. Tell me, will I see in peripheral smear in case of Thal minor NRBCs? Yes or no? What do you guys think? Will you see NRBCs here? You won't have NRBCs here, right? NRBC is diagnostic of a severe hemolytic anemia. It's not seen in Thal minor. Only target cells. Yes, by default, I'll see microcytic hypochromic anemia, poikilocytosis, everything, right? Investigation again for Thal minor, HPLC is better than hemoglobin electrophoresis. And the most important thing is HbA2 levels. The moment you see HbA2, anywhere between this value 3.5 to 7, mostly it will be more than 4 only, right? If you see HbA2, not HbA, HbA2 of 3.5 to 7, you think of a Thal minor. That's diagnostic. HbF will not be elevated. I'll see HbA also, right? And target cell to a normal cell. A normal, normal RBC is like this, biconcave. In case of membrane damage, I might have RBCs like this. Because of that, I have target cells. That's the reason for target cells. Irregular distribution of hemoglobin. Because of the membrane damage, you have target cells. Other name of target cells is podocytes. And the screening test for thal minor is Nestroff. That's an important screening test. Okay, if I want to go to a village and screen 100, 500 people, I can't take a microscope or a machine, right? We just do Nestroff. Nestroff is a naked eye, single tube, red cell, osmotic fragility test. Nestroff, right? Single tube, red cell, osmotic fragility test. What we do, we take 0.36% buffered saline in a test tube. Normal RBC, base of osmotic fragility is simple. You have an RBC, put in a hypotonic saline, water keeps on entering. At some point of time, it will become bigger and bigger and bigger and bigger and burst. Right? What we read about spherocyte, they are osmotically stable or fragile? Comment. Spherocytes were round and rigid. So less water enters cell, it will burst. They are osmotically fragile. Microcyte is like a balloon, not yet blown. So they are osmotically stable. So more amount of water it can take. So your RBC, my RBC at 0.36% will lyse. A microcytic RBC like thalassemia or even iron deficiency anemia will not lyse, right? That's a basic here. Microcytic RBC are don't like this like an uninflated balloon. That's for understanding, right? Are osmotically more stable. They don't rupture and the solution remains turbid. There is no hemolysis. If the solution becomes turbid, right? See here, this is how the clear supernatant is. If the supernatant is clear, which means RBC is lysed and everything has come to the bottom, which means here there is hemolysis happening here, which means this patient is normal in 0.36% sterile. In thalassemia, it will be turbid. Okay, if it's turbid, there's no hemolysis here, which means the patient is having more stable RBCs. That's why in 0.36% it's not able to lyse, right? In other words, how do you interpret? You look at them. If I am able to read through the test tube, it's clear. No hemolysis. Hemolysis has happened and the patient is normal. If I'm not able to read through the test tube, no hemolysis, supernatant turbid, and the patient is thalassemic, right? Ignore this part. Fine. That's for control. Fine. That's Nestroff. Nestroff alone can come in a 2-mark question if your university has 2-mark or 3-mark question, and worthwhile in asking a Viva as well. Fine. Perfect. So we know about thal major and we know about thal minor as well. Fine. Next is autoimmune. Ready for the quick rapid fire? Need a little bit of enthusiasm. Come on, tell yes, no. Only when I get 5 yes, I'm going to ask you questions. Then only I'm going to go to the next topic. At least 5 people should comment yes. Only then we are going to ask the questions. Then we'll go ahead. What's the fun, right? Next topic is about autoimmune hemolytic anemia. Can we ask questions? Yes, no. Abhinav, Saurima, Riddhi, Valikar, Ezra, if you guys are online, come on. That's great, Dr. Future. Okay. Only 2, 3, 4th and 5th one I'll comment myself, right? 4 of them. Okay, great. Let's go. So, autoimmune hemolytic anemia is the most common cause of spherocytosis, right? Can anyone tell me what type of immunoglobulin you will see in warm autoimmune hemolytic anemia? What's the type of hemoglobin you will see in warm autoimmune hemolytic anemia? You'll have IgG. IgG is the most common, right? In cold autoimmune hemolytic anemia, you'll have IgM. And there's a very rare subtype called cold hemolysin type. Generally, autoimmune hemolytic anemia, both of them are extravascular hemolysis predominantly, right? In cold hemolysis alone, I might have intravascular hemolysis predominantly. That's why you'll have hematuria there. The only autoimmune hemolytic anemia where you have hematuria is cold hemolysin type, right? What happens in IgGs? So here is my RBC. IgG binds to it. This roams via the spleen. Spleen will have the receptors for immunoglobulin, right? Macrophages. That will go and bind to the immunoglobulin and will eat the RBC also, lysis. But in IgM, it's a little bit different. That's cold. What happens is IgM will bind. IgM is weak guy. He cannot act alone. So he'll say, complement, help me. So IgM binds to the RBC. When it goes to the colder parts of my body, that's my finger, right? The peripheries are cold. It goes to the colder parts of the body, it will activate complement. But for a fraction of a second, it will come back again. Complement will go out. So in the fraction of a second, it cannot lyse. What it will do, it will have some amount of complement bound to the RBC, some amount of immunoglobulin bound to the RBC, same fate, goes to the spleen, dies. Both of them will not cause intravascular hemolysis. Both will cause only extravascular hemolysis. For both of them, I have few triggers. By default, the common trigger is idiopathic. I don't know. Other thing you can add is I can see them along with SLE by default for everything, because SLE is the biggest autoimmune disease, or drugs, right? Now let's go to the discussion. So autoimmune hemolytic anemia, warm antibody type is the most common subtype. Like I said, common is always idiopathic, right? Some part of medicine will make us feel comfortable. I also can write story and escape. Drugs, alpha methyl dopa, one of the important drugs. We have stopped giving them. We are giving them for pregnancy induced hypertension, right? Can be seen secondary to CLL, can be seen secondary to SLE. Here the autoantibody IgG is acting against Rh antigen. So what happens in the pathogenesis? So here I have an RBC. Along with that, let's say the IgG antibody is bound to the Rh antigen, right? It's bound here. This, when it goes via spleen, in spleen, we do have macrophages. Can you guys comment on the name of the splenic macrophages? Which will have FC receptor for the immunoglobulin, right? Constant change receptor, that's all. So the immunoglobulin binds here. Unfortunately, the RBC bound to also bind here, and then it will engulf and it will destroy. Okay. This causes classical extravascular hemolysis. Okay. Theoretically speaking, IgG is the strongest antibody, right? IgM is the weakest guy. IgG is the strongest antibody, right? So IgG binding to it theoretically can also sometimes, very rarely, cause direct damage to the membrane. This direct damage to the membrane can cause intravascular lysis. Write them in the exam, please write them, because theoretical, in real life it does not happen. Real life is always extravascular hemolysis without fail, right? Clinical features, I don't have any unique clinical features here. It'll have symptoms of anemia, more than, I won't have much. I might have history of drug intake, or of a lymphoid neoplasm, or of an SLE, or of an autoimmune thyroiditis, some other autoimmune disorder, right? Spleen may or may not be enlarged because acute condition, I might not have splenomegaly. Today I took a drug, had lysis today. Today's spleen will not become bigger, right? May or may not have splenomegaly. Sudden onset of fatigue, that's all. After intake, sudden onset of fatigue, it is diagnosed on a peripheral smear. What I did in peripheral smear? Classical spherocyte. The moment you see spherocyte, what's the next test? You do a Coombs test. Coombs test positive, I go for IgG. Then I can do a serology, say, okay, IgG autoantibody is present, my diagnosis sorted. Treatment, steroids. Plus or minus, remove the etiology. When I say remove the etiology, if drug is the etiology, remove them. As simple as that. If I have infection, treat them. Lymphoid neoplasm, treat them. That's how we remove the etiology. That's for warm autoimmune hemolytic anemia. The second is cold. In cold, I have two guys, right? So please, if I exam, the question comes, read what they are asking. Is it cold agglutinin type or cold hemolysin type? Both are different. Both are cold only, right? If it's agglutinin, IgM mediated, right? So here you'll have Raynaud's phenomenon. That's a very classical finding here, right? Infection can be in etiology, mycoplasma EBV. Mycoplasma has come multiple times in NEET PG exam. Mycoplasma pneumonia plus in hemoglobin drops, peripheral smear shows spherocyte, cold agglutinin hemolytic anemia, right? And also will be seen in CLL. I'll have more IgM antibody against I antigen. It's a minor blood group antigen, right? So what happens here in pathogenesis? RBCs, IgM binds to it. When the IgM travels to subnormal body temperature, that's very, very important. This will temporarily, they'll activate complements. This complement activation is so short, they cannot destroy them or lyse them. The only thing is very short duration, right? You write very, very short duration. Fraction of a second. Because the moment blood goes here, it automatically comes back to my core body temperature, right? So short duration, because of that, what happens? You will have not just your IgM activated to it, on also top of that, you'll have complement factors. You can write C3, you can write C5. They are also bound, right? So when this RBC goes via spleen, I have littoral cells. The only thing here is I have two guys whom I can attach to, right? So one is I can have a complement receptor. I can bind to the complement which is attached to it. Or as usual, I have the FC receptor for immunoglobulin, right? I can bind to the complement receptor. RBC is bound to the complement. I can eat them. Or I am bound. I have FC receptor. IgM is bound to that. I can eat them. By default, I'm going to have extravascular hemolysis only. Okay. Again here, history except for the initial inciting factors of CLL or infection, one classical history, that is Raynaud's phenomenon. Never forget that. That's where we started with, right? You'll have Raynaud's phenomenon. Why you have Raynaud's phenomenon? Because here I'll have agglutination of RBCs. That's why cold agglutinin type. That's classical in microscopy. You'll have clumps of RBCs. That clump can go and obstruct my vessels here, which can result in the paler, the blue color or red color change in the fingers, the acrocyanosis or Raynaud's phenomenon. Very, very classical. Again, Coombs positive. I can pick up serology. I can demonstrate IgM antibody. Diagnosis sorted. Treatment, same. Take care of the primary problem, steroids. That's how we treat cold agglutinin type. Next, last but not the least, cold hemolysin, or otherwise called as paroxysmal cold hemoglobinuria. Very, very rare. We don't see much of them these days, right? But it's a severe condition. This is a condition where IgG acts to its fullest of the power. It goes and directly damages RBC membrane. Generally, they don't do it. Here they are so vicious, so powerful, they directly damage RBC membrane and causes intravascular hemolysis. Okay? Rare condition, commonly seen in children. In previous decades or century, we were seeing most commonly along with syphilis. That time we used to call these antibodies as Donat-Lansstein antibody, right? So here you'll have IgG antibody against P antigen. 3 antibodies against 3 different antigen. IgG against RH, warm. IgM against I, cold agglutinin. IgG against P antigen, you have your, this is called as Donat-Lansstein antibody or cold hemolysin type, right? Okay. That's the 3 different types of autoimmune hemolytic anemia. Clear? Any doubts? Do let me know. No doubts, right? I didn't ask much of questions with respect to warm or autoimmune hemolytic anemia, right? So can you go to the next topic? Next 2 topics are not hemolytic anemias. We're going to go for nutritional anemias. If I am the examiner, I will ask only one disease in RBC disorders, iron deficiency anemia. If you know that, you're an amazing doctor. If you don't know that, even if you know every mutation in every other disease, you're not a good doctor. Because IDA will be close to 95 to 98% of anemia, what you'll see in real life. Rest everything is for theoretical purpose, just to satisfy our ego, that's all. Right? So next we'll go to IDA, right? So I'm going to ask you questions. I want you guys to answer them, right? Let's start. I'll ask questions with respect to normal iron metabolism. Then we'll go and discuss about the iron deficiency anemia per se, right? Which part of the body is iron absorbed? Oral cavity, esophagus, duodenum, ileum. Good evening. Okay, Sambri. Okay. Which part of the body iron is absorbed? Iron is absorbed in Fe3 plus form or Fe2 plus form? That's the second question. The absorbed iron directly goes to the bloodstream, yes or no? Or they'll be stored as some storage form. Great, Sorima. They're simple questions, right? Do comment. It's fine. If you make a mistake, doesn't matter for us, right? Iron is absorbed in duodenum. Absolutely right. Iron is absorbed in the Fe2 plus form, not predominantly in Fe3 plus. Fe3 plus also goes, but Fe2 plus is more important for me, right? And once it is absorbed, it will never go directly to the bloodstream. It will always store in the form of ferritin. It's stored in the form of ferritin inside the duodenal epithelium. Only when my body requires, iron will be sent outside. Who is the guy who will send the iron outside? Who is the guy who will send the iron outside from the duodenal epithelium into the bloodstream? Tell me the answer. There's a very important receptor there that helps and that controls iron metabolism. That is, you tell me, that is ferroportin. It ports iron. The moment iron comes outside, it will bound to 2 different proteins. One is serum ferritin, right? The other guy is transferrin. Serum ferritin holds 10% of the iron. Transferrin holds 90% of the iron, right? Okay. Transferrin will take the iron to your bone marrow, most common use of iron, and few enzymes in the body which also require iron as a cofactor. Transferrin job is that. What does the serum ferritin do? This is the storage iron, not the duodenal ferritin. Duodenal ferritin is not storage at all because I can never use them when I need. This is the serum ferritin, which is storage form of iron, and this is the serum ferritin, what I do in the blood test, not the duodenal ferritin. That we'll never be able to assess, right? Okay, perfect. So transferrin also goes and binds to one more organ. Can anyone tell me which organ? Apart from bone marrow, they also produce RBC. Apart from your iron containing enzymes, it goes and binds to one more organ that is very vital for iron regulation. What is the organ? That organ is, you know the answer, that is liver. The moment transferrin goes and binds to the liver, my body will understand, okay, this person has enough iron. Let's not send more iron to the blood. And there'll be one molecule will come outside, which is called as a master regulator of iron metabolism. That guy will go and block ferroportin. Who's that guy? A very important MCQ. That is great, but it's hepcidin. Liver releases hepcidin. Hepcidin will negatively regulate your ferroportin. It will suppress ferroportin. The moment hepcidin is there, ferroportin will keep quiet. No more iron coming outside. The moment transferrin loses iron, my body needs iron. Liver will stop producing hepcidin. Ferroportin will open it again. More iron will come into the serum and the entire cycle works. Hepcidin is the master regulator of iron metabolism, right? This is normal iron metabolism, right? There might be questions which will come on normal iron metabolism also, but iron deficiency anemia is a very simple topic. We'll look into that soon. Okay? Iron deficiency anemia, it's the most common cause of anemia. Whichever part of the world you go, underdeveloped, overtly superdeveloped, wherever you go, iron deficiency anemia by default is the most common cause of anemia. And the most common cause of anemia is nutritional deficiency. Or I have one more cause of anemia, which is excess loss of iron, right? Excess loss of iron can be in multiple places. In reproductive women, in the reproductive age group women, the most common causes for women, it is menstrual irregularities. May not always be menorrhagia, even normal menstruation, right? You lose up to 50 to 80 ml of blood every month. If you don't eat properly, it will result in iron deficiency anemia, right? Worm infestation. Which age group is more prone for worm infestation? Adults, children, middle-aged? Children. You must have read in microbiology, Ankylostoma duodenale and Necator americanus. It will lose 0.3 to 0.1 some grams of iron per day. You know the answer, right? Every single day I'll have iron loss, right? Worm infestation, something which has to be taken care of seriously, right? And this is how most of the elderly IDA will present with. This can be a clinical scenario. Okay, elderly person presenting with iron deficiency anemia, the most common diagnosis is do an occult blood in stool. You have to do it. If it's positive, look for endoscopy for identifying colon cancer. Predominantly old age iron deficiency anemia might be cancer related iron deficiency anemia only. Okay, most commonly colonic cancer, because colon, for a fact, you know that such a big lumen, right? Till I grow and completely obstruct the lumen, I won't have symptoms. So initial symptom will be blood loss, right? So these three are the most common known etiology. If you want to score extra marks, you can also write mutation related iron deficiency anemia. Transferrin mutation is there, I'm not denying. Nephrotic syndrome, I'll have transferrin loss, is there, not denying. This will take care of almost everything. Extra points, you can write mutation related iron deficiency anemia also, right? You'll have DMT1 transporter defect, that also is there, but not common at all, fine? Pathogenesis. The moment iron reduces in my body, this is the first stage, the stage 1, which is called as a negative iron balance. So what happens in negative iron balance is, the moment iron reduces, ferritin reduces first, because bone marrow is not having it, right? So ferritin is 90%. I'm not able to satisfy the need, so I'll have to borrow with someone. I have the ferritin, so transferrin is 90%, right? I'm not able to satisfy the need of bone marrow, so I borrow from ferritin. That's the initial phase. So serum ferritin, iron goes to serum transferrin. Serum ferritin is normal. So ferritin is reduced, serum iron is normal, then bone marrow also gets iron. This is the stage of negative iron balance. The balance alone shifts from ferritin to transferrin, but iron is normal, bone marrow is not suffering, there will be no anemia at all. But if you go for a few more months like this, I am borrowing all the ferritin's iron. Ferritin has also become empty. So what will I do? Automatically my bone marrow will suffer. That's my second stage. The second stage we call it iron deficient erythropoiesis. That's stage 2. Iron deficient erythropoiesis, where serum iron is still less. I am not eating properly or I am losing iron. Ferritin is also gone, literally zero. Then iron deficient erythropoiesis happens. So what happens there? I'll have reduced hemoglobin. I'll have smaller RBCs. But the most important thing here, MCH, MCV will be normal. Why? Today I am having deficient erythropoiesis. What does MCV stand for? Mean corpuscular volume. I have 5 million RBC per ml of blood. If today I produce small RBC, it will not affect the average, right? It won't. At least I need 60 days of smaller RBC to affect mean, because RBC lifespan is 120 days, right? So this is the second stage. Still, I am not able to correct it. Still there is reduced iron. Then comes your stage 3. Stage 3 is your iron deficient anemia. Hemoglobin is less, smaller RBCs, microcytic, hypochromic RBCs. MCV will be less, MCH will be less. Because here, the mean also is affected. Okay? Right? Not always, but that's a predominant cause. Nutrition is the predominant cause by default, right? So this results in the 3 stages of iron deficient anemia. IDA pathogens is important. Robbins does not describe much in detail, but I want you to know the 3 stages. These are must. Harrison describes it. Don't forget it. It's a long answer. I would expect a student to know all the 3 stages of iron deficient anemia, right? How do you diagnose? Simple. Symptom is pallor, right? Fatigue, like any other anemia. One classical finding, koilonychia. Theoretically, Plummer-Vinson syndrome, where IDA will be present with esophageal webs. So we might have dysphagia, right? There's one more important thing. In children, there's a very classical finding of history of IDA. Can anyone tell me what is that? Sure, yes, Walikar. Can anyone tell me what's that? You must have also experienced it. I have experienced it. They will keep eating chalk piece, pencil, many things. We call them pica. It's not just for IDA, it's for nutritional deficiency. Pica might also have nutritional IDA, calcium deficiency, quite a few nutritional deficiency, you'll have pica, right? Child, pica, worm infestation, iron deficient anemia. That could be the symptom in children. Adults might not have pica, adults will have different symptoms. Adults, especially women, one of the classical symptoms which is ignored is hair loss, hair fall. One of the very common cause. Keratin, no nail, koilonychia, this also is keratin. It will fall off, it will become thin, it will become brittle. Don't go to L'Oreal Paris, go to the lab, look at the hemoglobin, look at the iron. One of the common symptoms is hair loss and hair becoming broken, brittle hair, right? Okay, do a CBC, MCV is reduced, MCH is reduced. Like someone said, RDW, menstrual index, helps to differentiate thalassemia. IDA, wider RDW, menstrual index more than 13. Now, we'll also read why more than 13. Menstrual index is MCV divided by RBC in millions. Okay? That's menstrual index, right? In IDA, answer this question, we'll know why menstrual index is more than 13. In IDA, bone marrow will be hypercellular or hypocellular. What do you guys think? In IDA, bone marrow will be hypercellular or hypocellular? Undoubtedly, hypocellular. No food to eat, right? By default, they'll be less cellular. If they're less cellular, what's going to happen? So obviously, there'll be reduced RBC production. So what happens in menstrual index is RBC production reduces. That is, denominator reduces. So what will happen to numerator? Will become more than 13. Once the denominator reduces, numerator becomes more than 30, right? Combined, it becomes hypo, not hyper. Because no nutrition, they cannot divide, becomes hypo. Clear? Perfect. That's what happens in case of an iron deficiency anemia. Got it? Okay. Peripheral smear. You can write whatever it is. Don't forget this guy. This is a classical cell. Right? Pencil-shaped RBCs. Pencil-shaped RBCs are elongated RBCs. Plus, they should be pale. elongated and hypochromic. If they are elongated and has good amount of hemoglobin, that is elliptocyte. That's different. Elongated cell, no hemoglobin, pencil shaped RBCs, diagnostic of IDA. I can see teardrop, target, everything. In severe cases, I'll have everything, right? So the moment I have microcytic RBCs, I won't call it IDA. I will call it microcytic anemia. Do one iron study, right? Iron will be reduced. The moment iron is reduced, there's no one to bind in transferrin. Transferrin will be reduced. Ferritin is the most sensitive test. You know that for a fact. That's the first one to change. That will be reduced. If storage is reduced, TIBC is affinity to bind with iron. I don't have iron at all. So I show you even single iron, you'll go and bind it fast, right? You're not eaten. I show you any random dry snacks, water, you'll go and have it, right? So the moment storage reduces, affinity increases. Right? That's a classical iron profile. The moment I know, by default, I can say, okay, it's diagnostic of iron deficiency anemia. And how do you do? What do you do? You treat. You know that? Your comment disappeared. Can you reply, put the comment back so I'll answer that, right? Treatment is your iron tablets. TIBC Valikar is total iron binding capacity, fine? You know the iron tablets from pharmacology, right? Whatever tablets you want, ferrous fumarate, ferrous sulfate. But the most important thing is, I need to know if the patients are taking the tablets. How do you know the response? This has to be there in exam, right? Response should be seen after 6 to 7 months. Do a retic smear. If retic count increases, which means there is a good response because my bone marrow is hypoproliferative. I gave iron, bone marrow took the iron, divided and produced reticulocytosis, right? A very classical response because hemoglobin will take 1 month to increase. This will be just in 1 week, I'll be able to know the response, fine? See, okay, Kamran, Mensters index is MCV by RBC in millions, okay? We always use Mensters index for comparison. Mensters is not an absolute number. I don't look for 14.5 as the answer. I see less than 13 or more than 13. It's a comparative test. First, you have to understand that. I'm going to compare between your IDA and I'm going to compare between TAL. TAL is a hemolytic anemia. Since I'm going to compare between these two, what I do is I nullify the numerator because numerator is same for both. In both IDA and TAL, its MCV is reduced. They are microcytic, right? So since I'm going to compare between both, I'm going to nullify it. I'm going to make it 1. So the entire value of Mensters index is dependent on the denominator only because both are microcytic. I don't use Mensters index to differentiate IDA versus megaloblastic. I used only to differentiate these two guys. That's why I nullify the numerator. That doesn't matter for me because both of them I have microcytosis only. So in TAL, there's hemolytic anemia, more RBC, denominator more, less than 13 Mensters index. In IDA, hypoproliferative anemia, denominator less, more than 13 Mensters index. Clear? Based on stool appearance, I will not be able to say what anemia it is unless there is a worm infestation in the stool. Okay, perfect. Now let's go to the next guy. B12 and folate deficiencies. Fine. Can you guys hold on more? We have B12, folate, aplastic and your platelet disorders. Can you guys hold? Yes. Yes, Kamran. It's just for comparison. Fine. Few more questions with B12 deficiency. I'm going to go with the questions related to absorption. Can anyone tell me which part of the GIT B12 is absorbed? Not very good way to assess it, Kamran. Ileum. Perfect. Can anyone name the receptor which helps in the B12 absorption? This is a receptor which helps in the B12 absorption. The receptor name is tubulin receptor, right? There's one important factor in the B12 absorption which is secreted from the stomach. What factor is that? What's a factor which helps in the B12 absorption in the stomach? That's your intrinsic factor of Castle, right? Perfect. With respect to B12 deficiency, most of the deficiencies are absorption defects. They are not dietary defects at all. Because whether you are a vegetarian or a non-vegetarian, you will have B12. Vegetarians will have it in milk and milk products. Non-vegetarian will have it from meat. You will consume either one of them. Unless and until you are very futuristic and vegan, right? I don't like vegan people. Sorry if you're a vegan. If you're a vegan, you don't have B12. You will not have B12. That's one of the important deficiencies which is due to nutritional. The rest, everything are absorptive deficiencies, right? You'll have gastric problem. When parietal cells are gone, autoimmune anemia, autoimmune gastritis, or doing a gastrectomy, right? Autoimmune gastritis is your pernicious anemia, where I'm going to have antibodies against the intrinsic factor of Castle or antibodies against the parietal cells. They are gone, right? Medico, that is very rare. Mutation, transcobalamin deficiency, or your tubulin receptor defect are very, very rare. Let's not go to mutation at all. We'll go to common ones first, fine? Chronic pancreatic insufficiency, because that is required, the pancreatic proteases are required for the intrinsic factor to bind to B12. When that is gone, I'll have a problem again, right? Ileum, either surgically remove ileum or bacterial overgrowth, which covers the entire ileum and covers the tubulin receptor, or tubulin mutation, again very rare. That also can result in your B12 deficiency. Again, they are rare, but predominant of them are absorptive defects. If you look, all of these are absorptive defects. The only dietary defect is veganism. If you are a vegan, you'll have a problem, right? So the moment B12 is reduced, B12 is very, very important vitamin. B12 is involved in multiple chemical reactions. If you remember biochemistry, right? Cobalamin, right? It's very important. Along with folate, it will involve multiple things. One of the important problems in B12 deficiency is nuclear cytoplasmic asynchrony, right? Which means the cytoplasm matures, nucleus doesn't mature. That's an important pathogenesis in B12 deficiency and megaloblastic anemia, right? So here, nucleus does not shrink in RBC. So you'll have macrocytes. That's the first finding. Nucleus does not disappear in RBC so easily. So you'll have nuclear remnants, basophilic stippling, cabo ring. These are all due to nuclear maturation defect, because nucleus maturation does not happen, but cytoplasm matures. That's why the RBC might have good amount of hemoglobinization. MCH will be normal, fine. In WBC, again, it's so big megaloblast. It's so big blast. They're not maturing. They're not becoming smaller. So the bigger blast, when they come out of the bone marrow, they'll have multiple lobes. The hypersymmetric neutrophil is due to the megaloblast. They are again not maturing properly. The megaloblast, when they come out of the bone marrow, when they exit the bone marrow, they form more lobes. That's the reason for hypersegmented neutrophil. One of the classical finding for B12 deficiency or megaloblastic anemia. Fine. That's the reason the name also came, megaloblastic anemia. That's all. Hypersegmented neutrophil can be more than 5% of the WBC having more than 5 lobes. Some Indian books say more than 3%. In a Viva or an MCQ, whichever is the right answer, go with that. Okay. Or even one single WBC with more than 6 lobes, I'm going to call it hypersegmented neutrophil. The moment I see macrocytosis, hypersegmented, I'll be more inclined to call it megaloblastic anemia, not B12 deficiency, megaloblastic anemia. To call it B12 deficiency, I need few classical clues. Seen in both B12 and folate. Might be seen in both B12 and folate. Seen in both B12 and folate. Seen in both B12 and folate. Not specific at all. What's the only specific thing? Your neurological defects. Neurological defects is the only specific thing for B12 deficiency. It could be altered position sense, altered vibration sense. Okay, right? Sometimes even muscle weakness. You should have neurological deficiencies, right? This is a classical condition called subacute degeneration of spinal cord that you have to know about that, right? That's the only thing clinically can differentiate B12 from folate deficiency, right? The moment I know this, I do a B12 levels reduced, we treat with B12. Since majority of them are absorptive defect, treatment for megaloblastic anemia is always B12 injection, not oral tablets. Unless and until you are a vegan. If you're a vegan, you're not taking enough B12, give supplements. Because you give supplements, in none of these cases, right? In none of these cases, you'll have a solution, right? You give supplements, no pancreas, it won't absorb. Stomach is not there, it won't absorb. Ileum is not there, it won't absorb. That's why we give always injectable B12. That's a treatment for B12 deficiency, right? Folate, pathogenesis is same. Nuclear cytoplasmic asynchrony, that's all. Folate, predominantly seen in fruits and vegetables. Meat also folate is there, but the only problem is when you cook folate, folate dies. When it's a very heat labile vitamin, right? That's why fresh fruits and green leafy vegetables, lettuce, we can eat without cooking. That's more important for me, right? When will you have deficiency? Diet. Dietary loss, I'll have a problem. When the requirement is more, pregnancy or adolescence, you'll have a problem. That's why pregnant women is given folate by default. Alcohol, what it will do? It will interfere with the absorption of folate. And a few drugs. Methotrexate, never forget that. You know pharmacology, right? What is the methotrexate drugs mechanism of action? I want you guys to comment. Let's see how good your pharmacology is. Drugs also will be a problem. That's why when you give methotrexate, you know that folate absorption will be abnormal, and to circumvent that, you give one more drug as a supplement. What is the drug? You give folinic acid, right? Methotrexate is dihydrofolate reductase inhibitor. Once that is gone, I will not be able to absorb folate, and even if you give folate, it won't work because the enzyme is not there. So you give folinic acid as a supplement for it. Fine? Okay? Fine? Perfect. So clinical diagnosis, it will have same features like of B12 deficiency, the knuckle hyperpigmentation, you'll have the B-feriate tongue, everything will be there. Patient have pancytopenia also. The only thing is you will not have neurological deficiency in case of folate deficiency. Treatment, if only B12 is deficient, please treat with only B12, don't give both. If only folate is deficient, please give only folate, don't give both. If both are deficient, you can give both. Fine? Thank you, MBBS. Fine? Very, very important. This came in an exam. This can be also easily can come in reasoning why question. Fine? Because if you give both, let's say there's a folate deficiency, I also give B12, everything will improve without neurological improvement. That is very, very important. That's why we should not give both of them together. Please do remember them. Fine? That's about megaloblastic anemia, both B12 as well as folate deficiency, right? Let's go to the next guide. Few more things. I hope you'll hold, right? So PNH. Can anyone comment what is the classical symptom of PNH? You guys know that. What's the classical symptom of PNH? Classical symptom of PNH. It's early morning hematuria is a classical symptom of PNH, right? So what happens normally? In an exam, please don't write this. This is for understanding. Normally, when you, me, everyone sleeps, there is a little bit of physiological acidosis. This activates complement. Complement has C5 to 9 called as a MAC complex or a membrane attack complex. That goes and binds to RBC. At sleep, RBC will die. Early morning, you will pee blood. We are not doing that, right? We don't pee blood in the morning. Why? God or nature has created a beautiful mechanism. Whenever I sleep, I will definitely have complement activation. To stop that, I have these guys. 55 is called as a decay accelerating factor. Destroys the most vital C3 convertase. 59, membrane inhibitor of reactive lysis. Destroys the MAC complex. So though complement is activated, there is no destruction of the RBCs. My body is happy, RBC is happy. This is normal. Don't write this in exam. This is for understanding. So what happens in PNH? PNH is an acquired mutation. Please remember it. It's an acquired mutation. You can have it. I also can have it. Anyone in the world can have it. There is no inheritance. It's acquired, right? In X chromosome, there's a gene called as PIJ. It is not X-linked recessive inheritance. It's an X-linked X chromosome mutation. There's no inheritance at all here. Please do remember. PIJ codes for an anchor called as GPA anchor. So this GPA, let's assume this is an RBC. This is GPA. This red wala is GPA. Okay. This GPA is the guy who will hold CD55. Who will hold CD59. If GPA is not there, what will happen? Valikar, simple answer, no. If B12 or folate is not there, bone marrow will not proliferate. So RBC will be affected, WBC will be affected, platelets also will be affected. That's why pancytopenia. Fine? Okay. Let's come back to this. GPA is not there. 50-59 is not effective because they cannot come and bind, right? In the absence or deficiency of GPA anchor, absence of 55-59, which results in unregulated complement activation, which causes hemolysis intravascular. And the beauty is only early morning hematuria. Because the moment the patient wakes up, the physiological acidosis will stop, complement activation will stop, you will not have hemolysis. Clear? That's what happens here. Only early morning hematuria, diagnostic of paroxysmal nocturnal hemoglobinuria, a very important pathogenesis, right? Now, there is complement activation. I want you guys who is online, I want you guys to comment. There is complement activation. I know it will destroy RBC. Complement is a serum protein, right? Will it destroy WBC or only RBC? What do you guys think? Only RBC or WBC also? It will destroy WBC also. It will destroy platelets? Platelets also. So PNH is not actually only anemia. It's a pancytopenia. It's pancytopenia. Though I call it anemia because it's very evident. Patient will come and tell, you have red color urine. Patient will not say, doctor, my WBC is reduced, right? Okay? You're right, rabbit one. It will destroy everything, right? So, but early morning hematuria is a classical finding here, right? And the most common cause of death is thrombosis. PNH will have thrombocytopenia. At the same time, PNH will have thrombosis also. Contradicting, reasoning by question, right? So, why does PNH have thrombosis also? In PNH, let's assume this platelet, okay? Complements C5 to 9 is coming here. Platelet is completely destroyed. If it's destroyed completely, what will happen? You'll have reduced platelet count. Fine? Listen carefully. Is there a possibility I can destroy platelet half? Rest of the platelet is there? Is there? I either destroy it completely or I destroy it half. If it's partly destroyed, there's a problem there. When platelets are partly destroyed, it will release its factors. Granule contents. Will it cause thrombus? It will activate platelets. Part destruction will activate platelets. Activation of platelets will result in thrombus. That's why in PNH, you will have both thrombosis as well as thrombocytopenia. A very unique finding, and this thrombus is the most common cause of death. It can go and block the brain, stroke, cardiac vessels, MI. Can block it, right? Thrombosis is by default the most common cause of death, and it can also present Budd-Chiari syndrome, which is hepatic vein thrombosis. Very classical presence of PNH. Fine. Okay. I have given you why the thrombus also. You should know the answer. Fine. Okay. How do we diagnose? Do a CBC. You'll have pancytopenia. The moment you have pancytopenia, you look for bone marrow. Actually, I don't need this also. History is very, very classical for me to diagnose, but still, lab score will be reduced because lab is also a GPA anchored protein. So it will become 0 or reduced. Bone marrow, pancytopenia with a cellular bone marrow is diagnostic of PNH because most of the time pancytopenia is aplastic anemia, which is hypocellular bone marrow. This is a very important combination, pancytopenia with a cellular bone marrow. Other older tests, we had acid hemolysis test, sucrose lysis test. What we do here is we kind of mimic the sleeping method in a test tube. You take a test tube, acidify it, complement will get activated, will lyse. Acidified serum lysis test. Right? We do it in the lab, but we don't have it anymore because we have a beautiful and easy investigation these days. Fine? Aniket, tell me what's the problem. We'll definitely sort it out. Okay? Flow cytometry, we have 55 and 59. It's very good enough for diagnosis of PNH. If it's absent, it is PNH. If it's present, it is normal. But the best test is FLAIR. It's a fluorescent antibody. It's a fluorescent hemolysin, aerolysin, which will bind to GPA anchor. That's the best test because GPA is a problem in PNH. Fine. Okay. Even if 1% of the bone marrow cells are negative, it's diagnostic of PNH because it's a acquired disease. It need not be present in 100%. There are one complication of PNH. PNH can result in aplastic anemia because there are mutation in stem cell, right? Treatment, the best treatment is do a stem cell transplant. By default, the best treatment for PNH, there's one monoclonal antibody, very expensive antibody, which blocks C5. If C5 is blocked, C5 to 9 will not happen, right? It does not happen, will increase lysis, will decrease lysis, will decrease thrombosis. That's one of the most expensive drug available there, fine? That's eculizumab, which is drug for PNH, but PNH might most reliable treatment is your hematopoietic stem cell transplantation. Fine. That's regarding PNH. We know the pathogenesis, why it happens. We know the classical symptom. We also know why thrombosis happens in spite of having thrombocytopenia. We know the diagnosis, investigation chart, and also the treatment. Fine. Perfect. Aplastic anemia. Okay, the last gain RBC disorder. Okay. Aniket, tell me. Thank you, Zara Bach. All the very best. Do well. Okay. First of all, aplastic anemia is not an anemia. It is pancytopenia. Aplasia of the bone marrow. Bone marrow is not proliferating. Hyperplasia. You remember the first chapter. More division. Here there's no division. Aplasia. Right. So I can have idiopathic cause, the most common cause. I don't have any cause. I am yet to figure it out. Right. I do have inherited cause also. Very rare. We'll keep it in the corner. Aniket, I generally don't talk about valvular heart disease or electrolyte imbalances, right? Because it's not a hardcore pathology. I think you should go and ask Santosh sir. He'll be a better person because I also primarily don't know much about valvular heart disease since I don't see them. Same goes with electrolyte disorders as well. Fine. Okay. Let's come back to this. Fine. Secondary causes. I can have it secondary to hepatitis. Hepatitis is one of the most common infectious disorder causing aplastic anemia. Fine. Drugs, antibiotics, anti-cancer drugs, which can destroy the bone marrow directly. Okay. For which one, rabbit one? Complement system नहीं होगा तो antigen antibody को निकलेगा. Can you tell me with respect to what? I'll answer it, and if possible in English. Okay. Radiation. Radiation can directly damage the stem cells. Stem cells is gone. Bone marrow is definitely gone. Fine. Bone marrow failure symptoms also there. These are rare inherited cause of aplastic anemia. But I just want you to remember these two syndromes. Fanconi anemia, aplastic anemia with problems in the limb. Abnormal finger, something like that. Your thumb is not there. Think of Fanconi anemia. Or you have two thumbs, you're syndactyly. Think of Fanconi anemia. Disc keratosis congenita. Keratin, nail, right? You'll have nail changes plus aplastic anemia. Think of your disc keratosis congenita, right? Okay. These are inherited causes. Your pathogen is very, very simple. It's an autoimmune disease. Most of them are idiopathic, so we put them on autoimmune. So what happens is, any trigger, virus or drug which attacks the stem cell, they create new antigens, right? There's a normal stem cell, virus comes and destroys, a new antigen is produced. The new antigens are abnormally detected by my immune cells. That's my lymphocyte. The lymphocyte identifies the new antigen as foreign. So what they do, they produce antibody against the new antigen. But where is the new antigen? On the stem cell. So the stem cells are being destroyed, right? So these immunoglobulin destroy stem cells because the neoantigens are on the stem cells. That's why they destroyed. And obviously when stem cells are gone, we end up in having pancytopenia. Fine. Not at all, Nishkesh. You have to go back to 12th standard, complete that, and then let's look at this. Fine. Clinical features. These are symptoms of pancytopenia. Fatigue due to anemia, recurrent infections due to WBC loss, petechia, purpura, everything due to your platelet loss, right? Bleeding disorders. You do a CBC, you'll have pancytopenia. This is very important. MCV can be a little bit higher in case of aplastic anemia, do remember. The moment you have pancytopenia, I obviously look for bone marrow aspiration. Dry tap is a very classical finding. Aspiration, I won't have anything because there's no cells there. So what do? I diagnose them with bone marrow biopsy. In bone marrow biopsy, you should have less than 25% cellularity. That's classical. Normal cellularity is 100 minus age. Let's say someone is 30 years old. The bone marrow should be 70% cellular. If it's less than 25, it's aplastic anemia by default, right? Then don't ask me what will happen to a 95-year-old. I don't care about a 95-year-old having aplastic anemia at all, right? They already lived their life. Let's come back to the young age people. So what will happen is the bone marrow will be replaced by fat. If you see lots of fat in the bone marrow, that's diagnostic of an aplastic anemia. Fine. Peripheral smear, pancytopenia, but you'll have related to lymphocyte predominance. The reason is it's an autoimmune disease. Every autoimmune disease will have more amount of lymphocyte without fail. That's why you have related to lymphocyte predominance, and there'll be no splenomegaly. If spleen is palpable, it is not aplastic anemia at all. Fine. So this is what happens in aplastic anemia: less than 25% cellularity and more fat. Fine. We do have gradations. We call them severe aplastic anemia and a very severe aplastic anemia. If the bone marrow biopsy is less than 25%, and more than 2 of the following. ANC is absolute neutrophil count. Less than 500. Absolute neutrophil count less than 200. Less than 200 is very severe. Less than 500 is severe. Fine. Platelet count less than 20,000. Here also less than 20,000. Retic count less than 20,000. Here also less than 20,000. It's based on the absolute neutrophil count. I classify them into severe and very severe. Less than 200 very severe. Less than 500 severe aplastic anemia. Whatever may be the cause. We diagnose with bone marrow biopsy. How do we treat? We give hematopoietic stem cell transplant. That's the best one. We try lots of them. We can give steroids. Might work, might not work. We give immunotherapy, immunosuppression. You know, lots of immunosuppression drugs, right? Azothioprine, lots of them. Might work, might not work. There's one more important thing called an ATG, anti-thymocyte globulin. They have worked in quite a few patients. That may also help here in case of an aplastic anemia. The final resort by default is hematopoietic stem cell transplant in case of an aplastic anemia, right? Okay, that's the last one. Now let's just have a look at few images, okay? I'm going to ask you questions, images, and I want you to tell me what you think is the diagnosis, fine? I'll scribble a little bit, but I want you guys to be interactive. We are not having comments or answers for quite some time. Let's make it active. Let's rejuvenate ourselves, right? This is a normal RBC. Normal RBC will have a central pallor, right? Okay. If you have an RBC, which is multiple blunt projections, can anyone tell me what RBC it is? Multiple blunt projections on the RBC surface. What RBC is that? If you have an RBC, which is uniform projections throughout the RBC surface, what RBC is that? Uniform throughout the RBC surface. What is that? If you have a RBC like this, I'm not going to explain. You're going to tell me what RBC is that. Come on, fastest finger first. You know the answer. Kaleem, great. Poikilocyte is an irregular shape RBC, right? Great rabbit last one, so that will be side effect of the drug. You can't stop it. Having an infection versus losing the patient, having an infection is better, right? If you have an RBC which is like this, what is the RBC? Sickle cell, right? So this is an acanthocyte, multiple blunt, right? So the cystiocyte will not be blunt, okay? Cystiocyte will be sharp. If it's more than or equal to 3 sharp points, then that is cystiocyte or a broken RBC, right? Acanthocyte is blunt. Uniform is echinocyte, right? Or a bursal. Acanthocyte is spursal, right? This is target cell or codocyte. This is drepanocyte or sickle-shaped RBC. Fine? Okay? Perfect. We have 2 RBCs which will look like this. Can anyone tell me what will you name this RBC? This one. Rabbit one, hope your answer is sorted. If you have an RBC like this, there are 2 options here. It could be either a bite cell or it could be a helmet-shaped RBC, because helmet-shaped RBC and bite cell will look exactly the same in microscopy. Look at the history. Bite cell, history of G6PD deficiency. Helmet-shaped RBC, history of fragmentation syndrome, right? Like a DAC or a hemangioma or a microangiopathic hemolytic anemia, TTPHS, you look at a helmet-shaped RBC. Only history can differentiate that. Microscopy-wise, you cannot differentiate a bite cell versus a helmet-shaped RBC, right? Perfect. Okay, great. These are few things where you see echinocyte, uniform, regular, blunt throughout the RBC. You see in chronic kidney disease. If you have an irregular, it should have been irregular projections, blunt projections. You see even liver disease and A-beta lipoproteinemia. This is a repeat question. Don't forget it. Why I'm saying that? In both the conditions, my beta lipoprotein will not be normal. So the membrane is made of phospholipid bilayer. So it becomes irregular, right? Cystiocyte is a broken RBC, irregular sharp projections, and sickle cell anemia is in drepanocytes in sickle cell anemia, right? This is a different point, that's a different point. Don't confuse them, right? Cystiocyte, helmet-shaped RBC, fragmented RBC are all seen in microangiopathic hemolytic anemias or MAHAs. Fine. Okay. And there are inclusions. There are two types of stains in your RBC disorder. One is your Leishman stain, other one is a new methylene blue stain. If you have a single inclusion in a Leishman stain, it is whole jelly bodies seen in asplenia, splenectomy. If you have single inclusion in a new methylene blue stain, it's Heinz body, which is seen in G6PD deficiency. Clear? Rabbit, it's not destroyed permanently, right? So till I give the drug, it will be destroyed. I am not denying it. Okay? So the patient will have difficulty in eliminating complemented mediated infections, right? But still, I have IgG which can work. I have neutrophils which can work. I have macrophages which can work, right? So definitely there will be a dip. I'm not denying that's a side effect of the drug. Okay? Perfect. Let's go ahead. So if you have uniform multiple inclusions in Leishman, that's basophilic stippling, seen in case of megaloblastic anemia, seen in case of drugs, seen in case of myelodysplastic syndromes. If you have uniform in new methylene blue staining throughout the RBC, it's your golf ball inclusion seen in case of an alpha thalassemia. Okay? If it's non-uniform, irregular inclusion in new methylene blue stain, it's a normal reticulocyte. Fine? Same time, if you have, it's not papanema, if you have non-uniform inclusions in case of Leishman stain, it is Papanemer body seen in case of a sideroblastic anemia. Fine? Okay? Perfect. And Caboring is an inclusion body like basophilic stippling seen in all the conditions of basophilic stippling. Fine? Done? Okay. That's all regarding RBC disorder. So we have covered quite a few things in RBC disorder. We have seen almost every condition. We saw spherocytosis. We saw G6PD deficiency, sickle, thalassemia, autoimmune hemolytic anemia, PNH, iron deficiency anemia, megaloblastic anemia, as well as your aplastic anemia, right? Predominant of them, whatever is required is done. We also saw a few images to end with it, right? Clear? Any doubts with respect to RBC disorders? Throw it my way. I'll try to answer, and maybe 10-15 more minutes. We'll try to cover a little bit of your WBC disorders as well. Sorry, your bleeding disorders as well. Any doubts in RBC disorders? Yes, no, maybe? Anything? Let me know. No doubts? Let's go ahead. Fine. Quickly, 10-15 minutes, we'll be done with bleeding disorders. Then, obviously, I want you to go back, read the PPT once, and then call it a day. Tomorrow, come fresh, revise WBC and come. Fine? Okay. Now, in WBC, in bleeding disorders, I'm going to cover very few topics. One is ITP, the other is Bernard-Glanzmann, and also von Willebrand disease. Fine? These are three things. I'm not covering hemophilia because you know already many more things with hemophilia, so I'm ignoring it. That's all. Fine? Okay? Fine. So first is ITP. ITP is immune thrombocytopenic purpura. It is not idiopathic thrombocytopenic purpura first. So we have two types of ITP, acute and chronic. Acute is self-limiting, right? Like you guys have drop in the platelet after dengue fever. Sore throat, drop in platelet. COVID, drop in platelet. All of them are ITP. That's all, right? So mostly seen in children, seen post-viral. It is reversible. Within 12 weeks, it will come back. Don't say that I had dengue last week. Today, my platelet count is not still reduced. I'll go and need treatment. No, don't treat. Wait for 12 weeks. Not reducing after 12 weeks will push to chronic and start treatment. Okay? So chronic ITP, seen in middle-aged women, it's like a pure autoimmune pathogenesis. It needs treatment because it is not self-limiting. So what's the primary pathogenesis? I'm going to have antibody against some component of platelets. Who is that? You'll have antibody against the glycoproteins you already know. Right? 2B3A, 1B9. These are platelet surface glycoproteins. My body will produce antibodies to that. So what's the big deal? There is one change between this and autoimmune hemolytic anemia. The change is here, the glycoproteins are present in two places, both in the peripheral platelets and also in the bone marrow megakaryocytes. So what will happen? Platelets will bind to the antibodies. Let's say this is the peripheral platelets. Antibodies are there. This will go to the spleen. The splenic macrophages littoral cells will have the same FC receptors for antibody, will bind to it, will engulf, will destroy. Same to same pathogens of autoimmune hemolytic anemia. Done? That we already know, right? Okay. Here, in megakaryocytes, they do bind to the bone marrow also, which will destroy the megakaryocytes, which eventually will reduce platelet production. So here I have two problems. Not only peripheral destruction, and also in the center, my megakaryocytes are being destroyed. Right? So both of them will be destroyed. That slight difference in the pathogenesis between autoimmune and your autoimmune hemolytic anemia and your ITP, right? Perfect. So now, spleen is not palpable in ITP. This is a very important thing. This can come in reasoning wise. Listen carefully. This might be slightly confusing. So ITP have two places of destruction. One in the megakaryocyte, one in the periphery, right? So now, today ITP starts, destroys all the platelet in periphery via spleen. So spleen slowly increase in size. 2 weeks, spleen will not destroy anymore. Why? Because new platelets will not come, because in bone marrow this is gone, right? Bone marrow stopped producing after a couple of weeks. So there's no new peripheral platelets. Will spleen destroy? No. Will spleen work more? No. Will there be splenomegaly? No. Spleen will not be palpable in ITP because of the bone marrow destruction takes over peripheral destruction in a couple of weeks. Very, very important to remember, can come in reasoning wise. You can see autoimmune antibodies, serology is the way to diagnose. If at all you do a bone marrow, since platelets are being destroyed, automatically there will be hyperplasia in the bone marrow. That's classical for ITP, right? Peripheral smear, classical finding giant platelets. Giant platelets is nothing big. These are nothing but prematurely released platelets. That's all. In case of an autoimmune hemolytic anemia, you release reticulocyte, premature RBC. Same way, premature platelets are giant platelets. As simple as that. Fine. That's about ITP. And ITP, diagnosis is known. Treatment is simple. If it's viral infection, wait and watch. Any drug causing it, remove the drug. Otherwise, same for any autoimmune disorder. Steroids, immunosuppressants, worst case can remove the spleen. Fine. That's about ITP. Bernard-Silier Glanzmann, both of them are autosomal recessive disorder. Maximum thing can come in an exam for a second year is an addition defect, aggregation defect, glycoprotein 2B3A for Glanzmann, 1B9 for Bernard-Silier. Bernard-Silier will also have mildly reduced platelets. Glanzmann will have completely normal platelets. Glanzmann is a little bit more severe, can have internal organ bleeding. Bernard-Silier, just petty rashes, that's all, right? Both of the places bleeding time will be elevated. Diagnosis, do flow cytometry. GP2B3A, GP1B9 will be absent. If 1B9 is absent, that's CD42, I think of Bernard-Silier. 2B3 is absent, 41, 61, I think of Glanzmann thrombocythemia. Treatment, transfusion if required. This does not require treatment. Most of them, they are supportively managed. Just reassure, more than enough for them. Worst case of Glanzmann, I can do a bone marrow transplant or an hematopoietic stem cell transplant. That's a worst case of Glanzmann. Some case can be really severe, which requires it. Otherwise, just a platelet transfusion should be more than enough, right? Okay. Last but not least, von Willebrand. After this, I have scenarios. I want everyone online to comment on the right answer. Okay. Von Willebrand, the most common inherited bleeding disorder. Never forget that. As I said before, it's been multiple times asked. Most commonly autosomal dominant, have two defects, quantitative and qualitative. Okay, quantitative, both von Willebrand 1 and von Willebrand 3. These are both quantitative defects. In type 1 and type 3, quantitative. Type 1 is reduced von Willebrand factor. Type 3 is absent von Willebrand factor, right? Qualitative is function is not normal, but the amount of von Willebrand is completely normal. That is type 2. Type 2 is a qualitative defect. Fine. So in type 3, where von Willebrand is 0, factor 8 is very, very unstable. If you remember first year, you must read that von Willebrand binds to factor 8 to make it more stable. Right? Here it will be unstable. So it will actually present with like hemophilia. Your deep hemarthrosis, muscle hematoma, classical of hemophilia. Fine. Type 1 is the most common subtype. 70 to 75% type 1, where there is a reduced von Willebrand factor, not 0. How will they present? They'll present mostly bleeding after trauma. Like I said, the most common presentation is menorrhagia. because that's a classical trauma which is present in women in every month. So most of the women present in menorrhagia, that's the most common symptom of von Willebrand disorder, right? Unexplained menorrhagia. The reason why I have to diagnose them is later on, when the woman grows and gives birth to a baby, the same von Willebrand will also cause postpartum hemorrhage. We have to know them because we have a treatment. Treatment is intranasal desmopressin. You give that, this will release von Willebrand from the endothelium. So immediately it will take care of the problem, because in type 1, it's not absent von Willebrand, it is reduced von Willebrand. Endothelium is a storage area. I release them, the trauma, all of them will completely seal, right? That's simple thing about von Willebrand factor. And how do I diagnose? Do a von Willebrand factor assay. That's more than enough for us to diagnose. Before that, we have a test called an restostin agglutination test. In restostin, there'll be no clot formation, which thinks of von Willebrand disorder. Fine, perfect, great. So done with coagulation disorders and RBC disorders. So I have case scenarios. Let's see if you can give me the right diagnosis. Whoever is online, I want you guys to attempt here. Tell me the right diagnosis. Don't miss it. If you are wrong, it doesn't matter. It's an opportunity to learn so that in the real exam, you'll not make a mistake. Every slide, I'll put for maybe 10-15 seconds. I'll highlight the important things as you read. You tell me what's your most common diagnosis. What's the answer? I want you guys to keep commenting. 19-year-old. Most important, family history, splenomegaly, slight pallor, spherocytes, diagnosis. What's the answer? The answer? Great, great. I want everyone to comment. Come on, not one person. Everyone is going to write the exam, right? Classical case of an hereditary spherocytosis. The family history is very important. Adult is very important. Splenomegaly is also important for me here, right? Next question. Again, I'll highlight the important keywords. Not great history, but gender also helps here. Only 5 of you are going to write the exam. Of the 20 plus people who are seeing, come on, everyone should answer this. What's the right answer? Whoever makes mistake here, trust me, you will not make a mistake in the real exam. Great. That's a classical case of G6PD deficiency. Super, right? Next. I'm just going to highlight the important key factors here. You keep on commenting, we'll keep on talking about it. Fine. 36-year-old, recurrent episodes of dark urine on waking up. This is classical diagnosis, right? See, if it's easy and you think that I know it, it's easy, so I'm not commenting. Don't make a mistake. Comment. Sometimes you might make a silly mistake and miss on the long answer question answer here, right? That's a very, very, very classical diagnosis of PNH. A recurrent early morning urine, CBC showing pancytopenia. I'll ask you a leading question. Can anyone tell me this patient's bone marrow will be hypocellular or cellular? Comment on that, then we'll go to the next one. Rapid, you'll never forget that, right? You ask a doubt also based on it. Next question. The second part of the question should have not been there, right? Because it makes your life very, very, very easy. What's the answer? Great. The previous question answer is cellular bone marrow, right? Hypercellular or cellular bone marrow. This one answer. This is LKG question. I have given the peripheral smear shows sickle cells. It's a sickle cell anemia, right? Next. The biggest clue here is this. RBC disorder, 10 months. Only one diagnosis for me. Yeah, other findings also there. Poor weight gain, severe pallor. That's a thalassemia is not enough here. If you just write thalassemia, if I am the examiner, I will reduce marks for you for sure. I need the answer as thal major. I have a clinical feature which is suggesting thal major. It cannot be thal minor. Writing thalassemia is laziness, right? Completely. Thal major will be an appropriate answer. Beta thal or alpha thal doesn't matter for me. Predominantly beta thal, right? Not thalassemia. It should be thalassemia major. Fine. Next. Classical. This is menstrual lesson 13. That's a classical thing for. This will be thal minor. This don't write thal major because 23-year-old is not the age where thal minor major will present, right? It will be very, very early with thal major. 23-year-old should be a thal minor if it's thalassemia. Fine. Menstrual is less than 13 Mondal, it cannot be iron deficiency anemia. IDA, it will be more than 13. Fine. Why IDA again? IDA should be more than 13. Fine. Next one. Classical known autoimmune disorder. Coombs test positive. I'd go with autoimmune hemolytic anemia. I can actually prefer to call it warm on two bases. One, that's the most common. Second, I don't have a history of Raynaud's phenomenon. So I can call it warm, but I'll stick to autoimmune hemolytic anemia. That also is good enough for me. Fine. Next. This should be very specific. Don't go and call this as autoimmune hemolytic anemia. That's a mistake here. It should be cold agglutinin type of autoimmune hemolytic anemia. Not even cold autoimmune hemolytic anemia. It should be agglutinin type because classically there's history of Raynaud's phenomenon here, right? If you are able to make a absolute right diagnosis, go with that. Don't beat around the bush. Fine. This is actually the cold hemolysin type. This is not that common. So I'm just writing paroxysmal cold hemoglobinuria or cold hemolysin type of autoimmune hemolytic anemia. Fine. What's the answer? Diagnosis. Actually, I can pinpoint here, though I need iron profile to diagnose, the most probable diagnosis here will be IDA, right? Koilonic is very, very classical, which is diagnostic of an iron deficiency anemia, though I would need iron profile to confirm it. Fine. Though not a great question, this should have been vegan because vegetarian food does not increase the risk. Diagnosis. Here B12 deficiency should be the right answer. It should be B12 deficient megaloblastic anemia. Don't write just megaloblastic anemia. Okay? Because there's a neurological defect, which means it's a B12 deficiency, not a folate deficiency. Fine? This is folate deficiency. There's a history of folate deficiency. That's pregnancy, which requires more folate, right? That's a classical folate deficiency. Other history which can be is a person not having fruits and vegetables in his diet. That also could be history pointing towards folate. Or alcoholism pointing towards folate. Or having methotrexate for some other disease pointing towards folate. Fine. Fever, infection, gum bleeding, generalized weakness. Symptoms of pancytopenia. Most likely diagnosis. It's actually incomplete. Would want bone marrow findings before calling it an aplastic anemia. For now, I would stick to aplastic anemia, but need bone marrow investigations. I cannot say it's aplastic anemia just with this. Any pancytopenia will have this finding, right? It's not diagnostic, but any pancytopenia can have this finding. Fine. Okay. This is not ITP. See, because it's fever, infection. ITP is only plated problem. Fine. This could be ITP, right? Child recovering from viral fever. To be exact, this should be an acute ITP, not just ITP. It should be an acute ITP. See, these both ignore, they are a bit difficult to identify since childhood, right? These are for your Bernard-Solier syndrome and Glanzmann thrombasthenia. Cannot create a perfect history for it. You can diagnose them only on investigation, so don't mind if you make mistakes in this. But a very important clue, Glanzmann thrombasthenia can have a very significant history of delayed bleeding from umbilical cord. Okay, that can point to Glanzmann thrombasthenia. That's one of the important clues here. Fine. The last but not the least, mother having menstrual problems, von Willebrand disease. Provided it's an hematology question. It can be anything related to female genital tract also, right? If there's an option of all the hematological disease, then I'll bring to von Willebrand disease. Mother points to autosomal dominant inheritance, menstrual irregularity. That's the common way of von Willebrand disease being presenting. Fine. Perfect. Okay. So thank you for your time. You have given me close to 2.5 hours. Thank you for that. We have completed RBC disorders and platelet disorders. I'll send this to your Telegram channel of PW. If you're not there in my WhatsApp group, you can ping me. I'll try to add you as well. If you ping me most of the time, an AI will reply. I'll make sure that I take your messages individually and send your WhatsApp link. I have to create a new group. I'll create a new group and I'll add you there. I'll put the PDF in the WhatsApp group also. Let's make sure we read every chapter like this, slow and steady. But please, before class, read the notes and come so that it can be amazing. So, Rima, factor 13 as well as this. You'll do well, rabbit one. Don't worry about it. Fine. All the very best, guys. See you soon. See you tomorrow at 5 p.m. again. Bye bye. Thank you.